And Ahmad Hassan and Mamdouh will be joining us in a few minutes. We don't want just to run behind the time. Uh, so how can I see like how many? Yeah, so 24 participants so far. Are we expecting any more?
Yeah, yeah, yeah. The 26 now.
Yeah.
So are you able to share your screen?
No, I'm still struggling. But anyways, like for the introduction, we might not need to do something. I will send you the presentation for the clinical scenarios, and you can share it from your side. Uh, Now, guys, so let me take you through the course format. So it's 2 days. It's mainly clinical. It's mainly about clinical station. We are going to go through like systems, like so as explained in timetable. We've got a faculty from around the country. All of them have experience about the interview. I've gone through the process a couple of times at least, and they are in the training program either, or they have finished the training program and they are consultants. So please try to make use of us as much as possible. Ask any question that might be arising there. There is no stupid question. Just leave your questions in that question box. Um, I'm starting now by giving you some insights about the interview itself. So the interview format is going to be 4 stations. You will be rotating through the stations. You know, like for the last year, for the last 2 years, it hasn't changed. It hasn't to start with certain station. You can start like in portfolio, you can start in prioritization, you can start in communication or clinical station. So be prepared to start any of them, and then you rotate through all the other stations. Um, for clinical station, it's mainly two mini scenarios. Each will be 5 minutes. The first station, the first mini station is going to be 5 minutes and mainly about anatomy. And the second one will be about like the clinical knowledge. Um, we have tried to get most of the recalls from the last few years and condense it in a 2 days course. Uh, Please be aware that we are not going to cover everything. It's really hard to cover everything in just like 2 days courses, 4 hours each day. So it is it is your job to do the hard work, you know. You have to study your anatomy very, very well because we're not going to go through anatomy and stuff. All we're going to do is we give you a bit of insight how the exam is going to be, or how the interview is going to be, how to formulate your answer, how to prepare yourself, and the rest is yours. This is from England point of view. Is there anyone that has any questions regarding the interview itself or the clinical station specifically? Nothing?
Yeah, hi. Um, I just want to ask a quick question regarding the anatomy, actually. Would you advise about any source for studying the cross sections?
Yeah, knitters anatomy, and we did an orientation session, I believe, Mr. Suleiman. Did you upload this for the guys?
Yeah, I will be on the videos, but so we'll be on your YouTube channel. So you have an orientation session. I'll send it in the group as well.
Yeah, there is an orientation session that we've gone through everything, and we've mentioned some sources to study the cross section from. Knitters anatomy is one of the best.
Thank you very much.
Welcome. And that's true, guys. They love cross section. So I remember like there was pelvis cross section, leg cross section, thigh cross section, ankle cross section, neck cross section, and abdomen CT axial cross section. So they love cross section. So try to get familiar with like cross sections across all the body parts. And they ask you to name like the structures. Like, and it's around like seven, eight. And one of the interviews, I got 10 structures, and you have to name them in literally less than 1 minute. So you need to be like very familiar.
So Islam, they asking about the frame of interview. So I think this was covered completely in the orientation session, but just give them
But
an
yeah,
overview of
so yeah,
how they divide the
so
four station.
so the interview is four stations, 10 minutes each. I think it's being done now in one of the online platforms. I can't really remember the name, but yeah, Ahmed Hassan might join us now and let us know what's the name. But anyway, whatever. It's exactly looks like what we're doing now. It's like online platform. You just like do your ID check. You turn up like at least 30, 40 minutes before your time. One of the admin will join the room and just like you show your ID, and then she or he send you to the waiting room, and then like at your time you just jump into one of the stations, either portfolio, prioritization, clinical, or communication, and then you just like rotate between rooms. It's like after finishing, after 10 minutes, done, you out of the room, and then you're joining the next room. And for each station you keep your ID badge because you're showing it to the camera for each station, for each examiner. So it takes like a few minutes, sorry, a few seconds at the beginning of each station. So just keep it handy so you don't lose time, because you need every second. So this is, yeah, this is the general format. So for portfolio, we've gone through this, but yeah, let me go through it quickly as well. So portfolio is going to be one um, general question about your background, your portfolio, and they let you speak about like 5 minutes, 4 minutes, and then they ask you about something specific related to what you have said in your answers. Like, for example, if you mentioned a couple of publications or the project, leadership rule or whatsoever. So they ask you about this specifically, and they let you speak about 1 or 2 minutes as well. And then they ask you a general question about hot topic. And finally, they ask you like another like general question. So, for example, in my interview, they asked me about a property issue in a research project. So it's like it's a general question. For clinical station, we just mentioned is 2 5 minutes mini stations. The first one mainly is going to be anatomy based, and the second one is going to be clinical knowledge based. The communication station just started 2 years ago, and the theme 2 years ago, as far as I can remember, was about duty of candor. So you make a mistake and you go apologize to the patient and go through the situation. And the last year was about I think missed item in the patient. It's also about duty of candor, about how to go through the incident forms and stuff. So it's about like something that you might face in your day-to-day life and how to deal with it. But it's like scenario based. So they give you the scenario and just like talk through. Prioritization station is getting hard and hard. Uh, until the year before last year, it was just 6 patients, 7 patients, and you have to plan the list for the next day. But last year, the guys had like at least 12 patients each. So it's really hard, and it's time pressure. So unless you are very, very, very well prepared, you won't go through it. So my advice is uh, keep yourself busy every day preparing for the interview. Use all um, the resources around you. You've got registrars around you, you've got trainees around you, your consultants. You've got the trauma meeting every morning. So use the trauma meeting for like presenting cases, discussion, management plans, everything. And believe me, it's not stressful at all. There is nothing much more stressful than the interview. So it's like anything that you're doing every day is going to help, like the process of, if you know what I mean, desensitization, guys. So like if you get exposed to something so many times, you'll get used to it. So try to do that every day. Ask your colleagues from registrars or the trainees or the junior consultants just to sit down and do a couple of mocks for you. Try to attend as much mocks as possible. This will help you a lot. So I think Mamdouh joined us. So are you ready,
Yeah,
Mamdouh?
so
Yeah, sorry for being late.
no, don't worry. So yeah, sorry. Islam started an overview of the interview and about the clinical station. So we already run behind time. So
Okay.
if you take them through what's different in Wales application, then we
So
know and how to structure the answer from Islam, then from yourself.
I think if I share first, share screen,
Yeah.
1 second. So hopefully you will get all of you. Are you seeing this screen?
Yeah, we do, but we see you see
Yeah. So
your screen, not the yeah.
you see the shared picture.
Yeah, we do.
Yeah. So in Wales, it's online. Once you receive an email for acceptance and shortlisted, you will have an email similar to this. This was my email, and this is the similar email have been sent in the last 2 years. In Wales, you have two stations, and these two stations, with each station have two consultants, and each consultant they ask you different questions. You can start either by station two or station one. It's not necessary to start as the order. From the clinical point of view, from station one, clinical station and operative question, suitability and reasoning question. In this station, you will be asked similar as England. Some cases, they will bring you a picture, ask you a scenario. And as Islam, I entered in the last few minutes, but as Islam was saying, take any opportunity to deal with any case as your interview case. So if you are doing an A&E and you're seeing a patient with falling an outstretched hand, fush case, so give yourself a time in 5 minutes to go to see the patient, discuss with them, and ask them, and then go to your registrar, go to your consultant, and deal with it as a similar scenario case. It's not hard, it's a systematic approach. They will not bring you anything tricky. They don't want to trick you. They want to see your knowledge and your high order thinking in a way to say, you're safe, you can be a registrar, you know the protocols, you know the guidelines. In station two, it's about research and audit, and again, suitability and reasoning. So, this suitability and reasoning part, they ask you they can ask you again in the questions they asked you in the application of the Wales, why you are choosing Wales, why you think Wales is better. So you have to prepare your answer in a way it comes smooth. And again, as I told the colleagues who we discussed before, you need to give your point of view. Don't make it like a ChatGPT answer and then, no, this man doesn't talk as he's giving his reason or responsibility about something. Clinical stations, again, I can go to clinical stations. Clinical stations, if I forget to say something, it can be upper proximal humeral fracture. it can be elbow dislocation, it can be supracondylar fracture humerus, and it can be distal end radius. So common is common. There's nothing different. They will not bring you a certain case which you haven't seen before. Wales doesn't have the stations of prioritizing, doesn't have the cases as England. So there are only 2 stations, 30 minutes, 15 minutes for each station, and it's bang, 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 bang. Some papers you need to be aware for Wales about the studies, about the global studies which have been comparing different management, like a proximal humerus between operative and non-operative, like the knee scope, what's the outcome of the knee scope, and why you do knee meniscectomy. Is it symptomatic or placebo or what? These are the points. Other than that, Wales is simpler than England interview. That's it. I made it very quick and to the point because I don't want you to lose the track. Why? What's the difference in Wales?
Okay, ممدوح دلوقتي we need just to go through how they structure the answer for the clinical station. So just for the clinical
Okay,
scenario.
so I will tell you like a clinical scenario case. Do you hear me? I don't know. There's a freeze for a second. I will give you a small example. In my scenario, in my case, they asked me about. They brought a picture. 45 years old lady came to A&E, high BMI, smoker, non-compliant patient, fell at home, and they brought you an X-ray for a shoulder. At the end of the shoulder X-ray, there was a fracture of the proximal humerus. So when you start this question, I will approach this. She came in A&E. First important thing you need to structure this question is, I will approach this lady, I will take full detailed history, I will assume this is an isolated injury. If it's not an isolated injury, then I need to assess this patient according to the ATLS protocol. So they will tell you the next point, it's an isolated injury. So I will go to examine this lady. I will assess her. I will take a full detailed history in terms of smoking. And according to the notes, you have to say that according to the history provided, she's a smoker, high BMI. I will see who she's living with and what's her functional capacity and what's her hand dominance, especially if you're an upper limb. They will tell you she's a right hand dominance. Then I will do an X-ray for her shoulder. This is the X-ray of the shoulder. According to the X-rays, I don't see any dislocations, but at the bottom of the X-ray, it looks like there's a fracture line. And this X-ray doesn't follow the guidelines, so I need to have a joint above and joint below to include the whole humerus to have a proper assessment. Then they will give you the X-ray for the shoulder. Okay, so this is a fracture of the proximal humerus. Upper one third of the shaft humerus, and according to the AP and lateral, this is a displaced fracture. In my assessment, I will focus on. So whenever they ask you for something like that, you have to mention. You don't say neurovascular intact. My concern about these type of injuries, one is the axillary nerve injury. 2 is the radial nerve injury. I will assess this by doing 1, 2, 3, 4. Hand extension of the wrist, extension of the fingers, axillary patch sensation. And then based on the assessment, if she's neurovascular intact, I will keep her in a humeral brace, and then I will book her back again to the fracture clinic to be seen. He will give you another X-ray. So he gave me another X-ray, then say, this is the lady after 4 weeks of X-ray. What time you will bring her back again to the clinic? Then you have to mention this point. According to the BOOST guidelines, this patient needs to be seen within a week in the clinic. Any question, you can find a way to say the BOOST guidelines, according to the guidelines, even according to the guidelines of my hospital. If there's an open fracture or anything, you have to say, according to the guidelines where I'm working with, the antibiotics are 1, 2, 3. So mention guidelines in any question to show that you're safe. Then the patient came in the clinic, came after 1 week. What you will do in 1 week, I will do 1, 2, 3. I will reassess the fracture, explain for the patient, and then at that point, I will discuss with her options of surgical treatment and conservative treatment. I'm aware that these type of fractures can be managed according to the guidelines in a way of conservative treatment. I need to explain for the patients the risks and everything. Then patient came back again in 6 weeks time. The x-rays back, there's not sticky, the bone is not healing. What do you think is the reason? Then you have to say, according to patient history, patient high BMI, it's not fitting well because they brought me an x-ray, the humeral brace is not fitting properly. Then the humeral brace is not fitting. And then I think this patient is not compliant with her treatment. What you will do for her? Then I will offer her surgical treatment. What's your approach? This is the point. So we did interview, we were 20 person, did the interview, and I knew about 7 or 8 of them. Each one of us said a different approach, or most of them, they said anterolateral approach. But this fracture was upper 1/3 of the diaphyseal fracture. I said, I'm familiar with the posterior approach. Oh, you will do posterior approach. Why? Because I'm familiar with it. It's better in my hand, and I can do it. So what's your position? 1, 2, 3, 4. Why I'm saying this point? Because all of us can deal with the same fracture from different approaches, unless it's the standard approach for this type of fracture. Like a humerus, you can do an anterolateral and you can do a posterior if accessible for posterior approach. But don't come for the proximal, like a proximal humerus head and neck, and you would say posterior. No, it's deltopectoral. You need to know exactly how you can access this fracture. This station, 7 minutes, there's no thinking. Then the next question was meniscal pair, a meniscal patient. You will follow the same approach. You have to be safe. You have to be systematic. Don't jump from a point until you finish everything. And conservative management, in most of the cases, if accessible, you will do it. The same as you're doing in clinic, the same as you're doing in A&E. Similar scenario happened with the research and audit. They asked me, what's your project? I did, what's the best project you think you have done? I took one of the project, analyzed it, and said, my rule was 1, 2, 3, 4, 5, 6. And the outcome of this project is that. Then the consultant asked me, do you think all the registrars need to do a research? And my answer was no. I can't. Sorry, my answer was no. I don't need to. Not everyone, but actually they were expecting me to say yes. Registrars should do a research, but as long as I gave them reasoning, I don't think I'm not best one in research, but I'm trying to do my collaborative studies to improve my research portfolio. Guys, give your opinion on a solid ground. It gives you a better position in your. Don't just follow the flow to say yes, 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 yes.
Okay, Mamdouh, thank you so much for that. Yeah, we're just running a little bit behind the time. So now up to Muhammad Khalifa. He's one of both CCT fellows, arthroplasty fellow in Bournemouth. He used to be a Birmingham trainee. He helped me personally a lot during this process. So all to you, Muhammad Khalifa. Thank you for joining as well.
Assalamu alaikum, good morning. Thanks, Muhammad Hashim, for the invite and for organizing such course, and thanks, Islam, for the introduction. So I'm going to just share my screen now. Right, so can everyone see a slide with a hip on it?
Yes.
Yeah, we do.
Excellent. All right, so good morning. So over the next 45 minutes or so, I've been asked to talk to you about everything related to hip for the ST3 interview. So these are the topics we're going to go through. It's a busy slide, but don't worry, we won't be able to go in deep about everything, but I will give you what I think you should know about them and how to tackle the different station questions in the ST3 interview. So a bit about anatomy. I know no one likes anatomy, a bit dry topic, but I think my tip here is try to link it to how this will benefit you in the clinical practice. So about capsule ligaments, again, it's easy. You just need to know where the capsule inserts, and you should be aware that the capsule inserts around the intertrochanteric line, but it's a bit deficient posteriorly compared to anterior. This sometimes can get asked. The ligaments around the hip are easy. So basically, you put femoral, and then you add the 3 bones of the pelvic. So the iliofemoral, bubo-femoral, and ischiofemoral. The ligaments on the inside, 2 main ones is the ligamentum teres and the ligament transverse stapler ligament. And again, the clinical value, you'll know about them for the TAL, for example, during hip replacement, you put the cup position around it. And the capsular ligaments, you know about the intra and versus extracapsular fractures. And also it will help you to understand why we do certain maneuvers to reduce a displaced fracture, such as the Ledbetter maneuver. If you go to a blood supply, again, and this is also an FRCS level question, you need to understand the main blood supply in adults and everyone above the age of 4 years is coming from the medial circumflex femoral, which is coming from the deep femoral artery of the profunda femoris. This is the main blood supply. And then it forms what we call an extrasynovial ring just at the level of the basicervical or intertrochanteric line. And then it sends what we call the retinacular vessels and ascending retinacular vessels. These are the key ones because they can get injured in intercapsular fractures. You can see it here in this picture. And then it forms another ring just at the level of the subcapital fractures. It's called the subsynovial ring. And then they've got what we call epiphyseal vessels. So you've got the circumflex, ascending retinacular, and epiphyseal vessels. The biggest is called the lateral epiphyseal vessel, so medial circumflex and the lateral epiphyseal, to understand it this way. So this is the main blood supply. As any bone, you've got some contribution from a uterine artery, which goes through the intermedullary canal, again coming from the profunda femoris, and a small contribution from the obturator through the ligamentum teres. Again, this might be more in children and babies, but under 4. If you look about muscles, again, put a bit of clinical context. You understand this for approaches, such as the anterior approach. You need to understand these muscles and the posterior approach of the hip, for example, and also to understand why you do certain maneuvers and in terms of to reduce fractures and the deforming forces with proximal femur fractures. So again, I'm not going to go through origin and insertion and action and nerve supply. Again, you can look at these. Key muscles would be the psoas major muscle, the rectus femoris muscle at the front, the sartorius muscles. These are the key ones. Posterior ones can get a bit asked. They can show you this diagram, or they can ask you about the different muscles when you do certain approaches. So when you go to the hip to the back, you will find the glute maximus, the big muscle covering all of this. So it's been cut. This is number 1 here in the slide. Below it, you will find the abductors, which is the glute medius and minimus attaching to the tip of the trochanter. And then you've got the short external rotator, 6 muscles. Okay, so starting with the piriformis, the key of the hip, and then the obturator internus with the 2 gemelli, quadratus femoris, and obturator externus. It lies from the outside of the obturator foramen. Sciatic nerve is key. You need also to understand the root value, course, and function as well. Muscular spaces can get asked. I mean, the femoral triangle, which is the space at the front of the thigh, it's an imaginary space by the inguinal ligament at the top. So it's not a true boundary, it's just a ligament at the top. And then you've got the edge of the sartorius from one side and the edge of the adductor longus on the other side, this edge here. So adductor longus acts as part of the border and also at the floor. So the adductor longus and the pectineus. And as the name suggests, femoral triangle, so it's got the femoral artery, nerve, and vein, and some femoral lymph nodes, basically. Again, the clinical importance is to be aware of these femoral vessels. They can be quite close, and also for things like femoral nerve block or fascial block when you do necrophylacia. The other key one that can get also asked is the adductor canal, or what we call the subsartorial canal. Again, quite popular with anesthetic, especially with knee pathology, ACLs, knee replacement. They do an adductor canal block, and this is because the saphenous nerve is one of the contents. Again, it says subsartorial, so it's under the sartorius. So the sartorius is the roof, and it's called adductor canal. So the adductor longus is the floor, and you've got nothing else on the medial side except the femur and the vastus medialis. So it's quite easy. It's a triangle. So femur, vastus medialis, sartorius, and adductor longus. And again, the contents will be the continuation of the femoral vessels plus the saphenous nerve. Thigh compartment, it's not as common as the tibial compartment, so the leg compartment. But again, if you see this diagram, if you see one bone, this is thigh, two bones, then it's either a leg or a forearm. Again, it's quite easy. You've got anterior, medial, and posterior. 3 intermuscular septa, anterior, medial, and posterior. And again, if you've got the quadriceps muscle at the front with the foreheads, plus the sartorius, and the neurovascular bundle with the femoral artery and vein. You've got the medial compartment will be the adductor group, so longus, brevis, and magnus, plus the gracilis. So a muscle and a sartorius, the adductor, and the gracilis. And you've got the 3 hamstrings sisters at the back, the semiti, the semimembranosus, and the biceps femoris. And you've got here the sciatic nerve as the main vessel. So that's a dry bit about anatomy. You've got also lots of guidelines you need to be aware of. This is just some summary of the key ones. You've got the nice guidelines for the hip fracture management. They are quite comprehensive. And there's lots of overlap between different guidelines. So as long as you know them, roughly what they say, it should be fine. You've got the post care for the older or frail people. Again, nothing new. Probably you know most of them. You just need to like polish it before the exam and know what's inside each guidelines. Post management for pelvic trauma, urological injuries. You also need to know about the BPT, or the best practice tariff, for neck or femur fractures. And you've got this, if you've got time, I mean, I don't advise it, but you've got the BOA Blue Book. It's about 70 pages, includes everything about the NICE guidelines, the best practice tariff, and lots of other things. So it combines pretty much all the neck or femur guidance. So BPT, so best practice tariff. So if they ask you about it, basically it's an additional or bonus payment of about £445. They get paid per trust per patient. It's not a lot. I think they should pay more. But if, for example, for the trust I work in, we do more than 1,000 hip hip fracture a year. So this would be like nearly £500,000 given to the hospital in addition to the basic rate. So the basic rate being given, and this is additional. So it's an incentive each hospital not to lose such amount of money. And in order to achieve it, it's like, action potential from it's all or none rule. So you have to achieve all 6 or none. You don't get anything. Some of the stuff you will be responsible for it as a registrar, such as time to surgery within 36 hours. So when the patient arrives in ED and there's a diagnosis, confirmed diagnosis of neck or femur, the clock starts. And the clock stops by the time the anesthetic starts. So knife to needle, so time to needle in the anesthetic. So for 36 hours to optimize the patient as quickly as possible and get them to theaters. Then to be admitted under joint care, it has to be a consultant orthopedic surgeon and a consultant orthogeriatrician. Again, there's nothing much you can do about it. It has to be the trust responsibility. That's why we use performance, because you have to use an assessment protocol. So every trust has got its own neck or femur performer or booklet, and it has to be agreed by 3 departments: geriatric, orthopedic, and anesthesia. The orthogeriatrician need to see the patient within 72 hours of admission. So they ideally should see them pre-op and post-op, but they've got 72 hours to see the patient and document it. Post-operative should be an MDT, so you should be a geriatrician, orthopedic team, as well as the other departments such as dietitian, physiotherapist, occupational therapist, etc. And you should be, there is assessment for falls and bone health. So if you don't achieve all 6, the trust won't get the bonus. So that's quite easy. If you go to the pelvic trauma, again, why it's important? Because it's the only true acute life-threatening injury in orthopedics. So ignore everything about open fractures, compartments, etc. The only true life-threatening that can kill a patient is an unstable hemodynamically pelvic fracture. That's why there should be no mistakes, and everyone should be aware of it, regardless of their own specialty. The key things of this guideline is to save life. Save life. Okay. So some of the stuff need to be done pre-hospital, such as binder, for example, to be done on scene. TXA, tranexamic acid, need to be given within an hour, as soon as possible, up to 3 hours. There's some debate beyond 3 hours, and probably you shouldn't give it beyond 3 hours because it can paradoxically increase mortality. The patient should be shipped to a major trauma center, ATLS protocol, trauma team. You call the massive transfusion protocol, and you put the patient quickly in the CT scanner. CT should scan the patient with a scanogram from vertex to toes, so whole patient scanogram, and a CT slices from head till the lesser trochanters. This is the UK practice. I know ATLS says you should get an X-rays, you do a fast scan, etc. But in the UK, it's a trauma CT scan. Sometimes the binder is not applied on scene, and it's your duty as an orthopedic registrar to put the binder and to look after the C during the trauma call. Again, depends on different hospitals. But binder application, they can ask you, what is the binder? How do you apply it? What are the alternatives? How long do you leave it? It should be applied at the level of the lesser trochanters, and it should be tight enough to be uncomfortable for the patient. And you can use, for example, a wrapped sheet if nothing there, but most hospitals would go have the binder. You can leave it as long as it's needed. Even if the patient go for a laparotomy, you can keep it because it's not around the iliac crest, it's not covering the abdomen, it's around the lesser trochanter, the greater trochanters. And you can leave it up to 24 hours. Beyond that, there's no evidence it makes any difference, and it can cause pressure necrosis because remember, they have to be put really hard. Okay, what are other duties as a registrar? You should get a pelvic X-ray for any patient going for surgery. So if the general surgeon or taking him for a laparotomy, you should get a pelvic X-ray, even a portable one, before they go to the OR. You should also get what we call a post-binder X-ray, even if the CT scan shows absolutely no fracture whatsoever. You still need to get a post-binder X-ray. And there is lots of evidence. There are some studies, one of them from Bristol. They mentioned that a perfectly reduced APC or open book pelvic fracture can look completely normal in a CT scan, and then they have a massive symphyseal diastasis once the binder is removed. They can ask you about what to do if the patient is not stabilized after a binder. Again, you make sure that patient has got enough blood going, so you can lose few liters in the pelvis. So you have to give them, it's not like I've given 1 unit of blood and he's not stable. They should get, I mean, a minimum of maybe of 2 liters through rapid transfusion, maybe sometimes up to 5 liters. And there are some good evidence that unstable pelvic fractures need between 5 to 10 units at least to stabilize. If not, then each hospital should have a policy, whether you take them for a pelvic packing or you do an interventional radiology, depending on whichever quicker. So time to needle or time to door, whether you can get them to the IR suite or to get them to the operating theaters. And again, there are some debate, such as venous bleeding, which is the commonest, is better to control by packing. Arterial bleeding, especially if you can see a blush on the CT scan, better with IR. But again, don't get into these debates. It depending on which hospital. You should just understand that these are the treatment. Don't go into the realm of I'll put an X-fix, I will do something else, I'll put SI screw. These are not resuscitative measures. And then once the patient is stabilized, you've got to operate within 72 hours to definitively fix the pelvis. And again, this has to be discussed with a pelvic surgeon experienced in such fracture. They can do external fixator, they can do internal fixator, they can do symphyseal plate and SI screw. So depending on 72 hours. And then once you've got the diagnosis, some patients may not need the binder, even if they initially was unstable, such as if they have vertical shear, it's better to give them traction later on. Or maybe if it's a lateral compression and the patient is stabilized, you can take the binder off. Sometimes the instability can be due to a tension pneumothorax or something else, not just the pelvic. But a lateral compression doesn't need a binder because you actually make it worse. If there is injury to the urethra or bladder, You should be aware of that, and you should anticipate it and expect it in every single case because it's high energy trauma. So when you mention the ATLS, again, when you go to the E, exposure, you should say, okay, I will look at and it's like the driving test. You should say, I will look at the perineum and make sure there's no perineal bruises, no lacerations, no blood at the meatus. If there's anything like that, then you suspect there is a urethral or a bladder injury. Again, also open fractures can happen if they have rectal injury, vaginal injury, and open bladder injury. You need to mention that this should be treated as an open fracture guidelines with antibiotics, etc. So what happens if there is? I mean, the guidance is quite clear. You don't need to think. I mean, even if there's blood at the meatus, you can still put a catheter, 16 French, by an experienced doctor. And you are the experienced doctor. You put the catheter. You don't need to call a urology for that. And then once you put the catheter in, one single gentle pass. Once you do it, you can do now a cystogram, so to assess bladder. And you don't need to think how to do it. It's already written in the guidelines. So if you can't pass it, then you just put the catheter at the tip, inflate it, and do a retrograde urethrogram. You can show sometimes an X-ray of a retrograde urethrogram with a pelvic fraction. Don't get too anxious about it. You can just say it's a retrograde urethrogram according to the guidelines. And it's very clear how to do it. You inject 20 mils of diluted contrast, and then you take an X-ray. So I'm not gonna tell you it. You can read it. So basically, this is how you deal with urethral fractures. And then what? If there's no injury, that's fine. You put the catheter in. If there is injury, then you call urology, and they should put a suprapubic catheter. And again, this is quite important. It has to be in the midline, and it has to be 3 to 4 finger breadth above the symphysis. Why is that? Because you don't want to soil the approach for the symphysis plate or the stopper approach for the pelvic fracture. So it needs to be high enough to avoid. If they do it right on the symphysis, then you can't fix it now, or you have a high risk of osteomyelitis later on. And again, as we mentioned, bladder injury should be treated as an open fracture. And again, there's difference. If the bladder is ruptured intraperitoneal, you should repair it. If it's extraperitoneal, you can drain it. Unless you're going to repair the pelvis anyway, you can repair it as well. But again, yeah, this might get quite technical later on. Right, so let's hope everyone is okay so far. In clinical stations, they can ask you approaches, and I find it you can go through either AO surgery reference or you can go through ortho bullets. They've got some nice diagrams, and also they write it in a really structured way, so you can refer to that. But there is a certain spiel you should say for any approach. So what are the indications, or what would it expose? Patient positioning, surface marking and incision, how to extend it, and then an intermuscular plane and an internervous plane, and then structures at risk. These are the 3 things you need to mention. Which muscles you go through, which nerves, and what are at risk. And then you describe it layer by layer, and then they can ask you about the pros and cons of this approach. In the hip, 3 directions. You can go from the front, you can go from the side, you can go from the back. So a Smith-Peterson approach, a modified Hardinge, which we're all familiar with, a Southern approach or Moore approach, or the Coca-Lange-Bick approach if you go from the back. So again, we're not going to discuss each approach in details, but basically the anterior approach, why I should know it? Basically for the last thing, irrigation and debridement of an infected, say, native hip in children or an adult. Again, as a general orthopedic surgeon, on calls, I mean, me personally, I've done it 2 or 3 times for this indication. You can do it for total hip arthroplasty, quite elective settings, only a few people do that. You can do it for biopsies and fusions, again, very rare. But you can do it for DDH, open reduction. Again, I've done it a few times as well during my PEDS rotation. So it's a quite important approach to understand. And the reason they like it is because it involves lots of dissection, and it's got internervous plane and intermuscular plane. That's why it gets quite asked. So patient is supine. Again, you can give them the cherry on top, like to tell them that you've done this before. So patient is supine. You put a sandbag under the ilium just to lift it up to make sure that you've got good exposure. The things might give you extra points against other candidates. And then be confident. Don't say, I can make an incision about 5 or 10 centimeter. It can be a bikini incision. Just say, I'm going to do a straight incision. My landmarks are from the iliac crest symphysis ACIS, and then I go along the front of the thigh towards the lateral part of the patella. So this is how we describe it. Okay, don't give too much variables. And then you've got the internervous plane between the sartorius. Remember the muscles from the anatomy, tensor fasciae lata. Again, this is the femoral nerve, superior gluteal nerve. And then you go deeper, you will find the rectus femoris and the glute medius. Again, same nerves, but different muscles. And the structures at risk. You have the lateral femoris cutaneous nerve. Again, as it comes out from the deep fascia in front of the ACIS, you should be aware of that. And also, you can tell them there is a vessel ascending branch of lateral circumflex as you get deeper. Can bleed. I'm aware of it. I will ligate it. So give them an idea that you've done this before, even if you've not done it. Lateral approach, I'm not going to talk about it. You've done it a million times doing hip hemiarthroplasties. Again, patient is lateral, no internervous plane. And there is no true muscle plane because you basically just go through the gluteus medius minimus tendon and you lift it up. Just remember the superior gluteal nerve is very close. If you split the gluteus medius too much beyond 5 centimeters above the GT, you can injure it. But no one needs to go above the GT by 5. Usually, you go above the GT and then you curve around the femoral neck. You don't need to go that high. Again, the use is for proximal femoral fractures according to NICE guidance. Total hips, some surgeons do it, but it's fallen out of favor. Posterior, patient is, again, sorry, this is wrong. Patient is lateral, not supine. Again, internervous plane, again, no true plane, no true muscle plane, because basically you split the glute max and then you cut the short external rotators, which we've discussed earlier. It's quite important to understand the structures at risk here. So you can damage the inferior gluteal nerve if you go too much proximal. Sciatic nerve is just right here behind you. You have to stay away from it and to identify it. And if you extend the incision down to the quadratus femoris, you will find the medial circumflex femoral and you can injure it. There are some variations. So if you do it for a hip replacement, you can go bold, cut the muscles, cut the circumflex. You're replacing the hip anyway. But if you do the modifications such as the Coca-Langerbeck, the incision should be slightly anterior to give you a bit more exposure of the ilium, and you obviously don't cut the muscles, and you should be aware of the medial circumflex femoral. Otherwise, this hip is gonna go into AVN. Approaches, again, there is this box here for any surgery. If they ask you about how would you do this surgery, again, the orthobullet AO surgery reference is quite good. Again, indications, prerequisites, so what you need to achieve, and positioning. You can say this appropriately marked, consented, WHO checklist patient, our position patient, XYZ, antibiotics, prep and drape. Just develop a way of saying it quickly but comprehensively. And then you will mention the approach. Again, sometimes if it's about the operation, they will say, okay, now we've done your approach. Tell me what would you do. So they will ask you. So don't get too bogged about saying the approach. Okay, they want you to talk about the operation itself. And then you mention the key steps. Remember the buzzwords for any operation, what they look after. They can ask you about the instrumentation, what instruments to use, and then the closure post-op care. And at last, the follow-up. How would you follow up the patient, and if there's any complications? It can be a medical complication or a surgical complication. Things to be aware of: dynamic hip screw, hemiarthroplasty, IM nailing, cannulated screws, MUA for a native hip or a THR. They can talk about hip replacement, acetabulum fracture, but I think this is more than an FRCS level. DHS instruments, you should know them inside out. The traction table, they may not ask you about it, but it's a good thing to familiarize yourself with the traction table in your hospital. And the Ledbetter maneuver, which we're going to talk about. For operations, you've got for trauma, the AO is very nice. Also, Oracle, it's with subscription. If you got a BOA membership, they can give you some discount, and sometimes you can have a free trial for about 3 months. I've used it till I finish my FRCS, and then I've canceled the membership. You can go through the OPTEC or the surgical technique for different manufacturers. And there are some nice videos on Vimeo as well. Yeah, you can see different operations and instruments. So this is example, some screenshots from Vimeo. They're showing a DHS kit and how to set up a traction table. Again, you should know the instruments inside out. They can give you labels and point different things. So be aware of that. as well. Right. So now we've done the knowledge bit. I'm gonna give you some demonstration. How would you put this in clinical scenario? So if they show an X-ray like that, I mean, we all know there's an intercapsular fracture of this side. So, but you should have a way of describing the X-ray, sounding comprehensive, but also not sounding like a medical student or undergraduate. You're a registrar, so you should say, yeah, this is the pelvic. So I would say ABC approach, which is A, which is the adequacy and alignment. So this is an AP projection. It's not adequate because you can't see the iliac and the lower lumbar vertebra. So AP, adult patient, inadequate, missing the part of the ilium, showing what? B. B is bones. So showing an intercapsular fracture of the left hip, it's displaced. And then you put some extra bits. I mean, it's an intercapsular, it looks displaced. It looks in the maybe transcervical region. And you can say broken Shenton line. So you give them, how did you do that? By broken Shenton line, so you get extra points. There's proximal migration of the shaft. There's external rotation because the leg would be short on external rotation. You haven't said anything new, but it gives you extra points. Okay. And then C would be anything else, soft tissues and things. But yeah, there's no catheter, there's no retrograde cystourethrogram, there's nothing else. So if there's nothing, you don't need to say no about it. Okay, so that's the diagnosis. So again, describe the diagnosis, and then they can ask you about the management. They can get you to approaches. They can ask you about surgery. And if they ask about surgery, they can ask you about consenting. So again, it's a fair game to understand consent for different hip fractures. And again, post-operative complications. So again, don't make up management. You just follow the guidelines. So for example, if the fracture cannot be seen, the guidelines in NICE say you should get an MRI scan. And how long would they allow you? 24 hours. If you can't get MRI for 24 hours, you can get a CT scan, or if MRI is contraindicated. And again, a CT scan should be done as soon as possible, under 24 hours. And then when to do the operation? 36 hours, which they say on the day or the day after. And then this is your responsibility. You've got this time period to treat correctable comorbidities immediately. So surgery is not delayed. So the management will need to investigate and look for those correctable comorbidities to correct it before the operation. So that's why you do a full blood count. You do INR. You take history of anticoagulation. You should stop anticoagulant for 24 hours to 48 hours, depending on the eGFR. Correct dehydration, electrolyte imbalance, uncontrolled diabetes, uncontrolled heart failure, cardiac arrhythmias or ischemia, chest infection, whether it's acute or acute and chronic. That's why you do a chest X-ray. You listen to the chest. So that's why when they say, how would you manage? You said you do a full history and examination. You look for correctable comorbidities such as X, Y, and Z. You do a blood test, X, Y, and Z to look for that things. You optimize the patient basically. Then analgesia and nerve block, again, has to be multimodal. We start with paracetamol, go to opioids, but also use nerve blocks. Not sure, they may ask you about how we do a fascia iliaca block. I've not done it in a long time, but there are different guidance. You can do it with ultrasound. You can do it what we call the double pop technique and the landmark technique. You can read about it. Some hospital, the on-call team does the fascia iliaca block. And then patients should be on a planned trauma list. You don't do them overnight. It had to be on the next day. You don't put traction. There's no traction. There's no bohlar. There's nothing like we used to do in Egypt or other countries. Patient just lies on the bed for neck or femur fractures. If it's a shaft fracture or if it's like periprosthetic, massively displaced, yes, you can put traction on that. But for a simple trochanteric or intercapsular, no traction needed. When you do the operation, there is nothing like, I will put the patient touch weight bearing, partial weight bearing. You should operate to allow elderly people to full weight bear. And if it's intercapsular, you do a replacement arthroplasty. They don't say fix it if it's undisplaced or displaced. So the guidance is black and white. Intercapsular replacement, and use a cemented implants, and use an anterolateral approach, unless this patient has got these criteria. And this criteria was changed a month before my FRCS exam, was in 2023. They said those who would offer a total hip replacement need to walk independently, outdoors with one stick, have no significant comorbidity or condition, again, bit vague, what is significant, and also to be expected to carry this level of activity independently beyond 2 years. So يعني عايش بالمصري كده اللي هو is gonna live more than 2 years doing good activities. They left it a bit vague and they left it a bit high threshold. So if you look at most neck of femur fractures, I would say less than 10% would go into this category. Maybe less than 5% of people with intracapsular would fit this criteria. So I have a really high threshold to give them hip replacements. DHS for any trochanteric, don't go into the realm. I'm going to do a short nail DHS, any extracapsular trochanteric DHS, except the reverse oblique and the subtrochanteric IM nail, and I go for a long nail. And again, they should under an NDT approach and rehab, as mentioned by the BBT. Again, these are some X-rays. Again, if you see this one, you've got fracture going this way from the GT to LT. Even if the LT is fractured, a standard 4-hole DHS would suffice. Don't say, I'll put a 6-hole, I'll put a 5-hole. I would do a plate, just a DHS, okay, according to the guidance. This is the opposite. It goes from the LT to the below. This is a reverse oblique. It has to be through a nail, and it's go through a long nail. And this is a trochanteric fracture. Sorry, a subtrochanteric fracture, again, long iron nail. They can get a bit tricky, these ones. So you might need open reduction. You might need some other techniques. This, for example, it's again subtrochanteric, but it doesn't look like the previous one. It's not comminuted. It's not spiral. It's just a clean cut, as if you cut it with a saw. So it will alarm you that this might be atypical bisphosphonate type fracture. Bisphosphonate are the commonest, but they are not the only ones. Some other medications, statins and things can cause that. But bisphosphonates are by far the commonest. They will have prodromal symptoms. They should be on bisphosphonates. And they may have it on the other side, if you see here. So you will find thickening of the lateral cortex, and you find the no comminution on the medial cortex. That's the clue. Okay. Again, if you see that, you should not take it easily. I mean, it needs a long nail. It needs a thick nail because it doesn't heal very well. So you need a nail that would withstand the stresses for a longer time. You should ream it. Don't go unreamed to encourage healing. You may need to put an augmented plate, a unicortical plate. You will need to open and reduce it. So it's not an easy one. And you need to follow up this patient maybe a year, maybe 2 years to make sure it heals. This one here, again, similar to the first one, is a bit less displaced intracapsular, but this patient, for example, is 40 years of age, so young patient. Again, you're not gonna throw the hip away and replace it. Under the age of 65, or maybe 60, so 60 and above, you can say, I would do a replacement according to the guidelines, but below the age of 60, you should be aware that you can preserve the hip. And again, the current guidance is about the quality of reduction, not time. Don't say, they might push you, would you leave him till the morning? Would you do it overnight? Again, there's no evidence that rushing to do the operation overnight makes a difference if you don't do it properly. However, you don't leave him on the ward for a few days. Again, ideally within 12 to 24 hours. There are some evidence beyond 24 hours, they may get long-term complications. So don't leave him too long. Again, he still needs to be done by a hip surgeon on a planned list within 24 hours. And the aim is to get anatomical reduction and rigid fixation, okay? So again, how to reduce it? This is the Ledbetter maneuver. So again, you have to flex the hip, internally rotate, adduct, and why you do that? To relax the muscles, the iliopsoas, and also to relax the hip capsule. You unwind the iliofemoral ligament. So once you do that, you put traction, and this will allow the hip to reduce, and then you keep the traction on, and gradually, and keep the internal rotation on, and you gradually extend and abduct the leg. It will reduce, I would say, 90-95% of all intercapsular fractures. Some fracture might move. If they say don't reduce, then you have to do an open reduction. You can repeat it once or twice, but don't keep doing it lots of times because you can damage the blood supply. And then how would you fix it? 3 cannulated screws. You can do this new fancy FNS system, femoral neck fracture system, if you've got it. If you know it, say it. If you haven't used it before, don't say it. Or the classic old 2-hole DHS and D-rotation screw. Again, they would say, okay, I mean, to play it safe, say for every case, you will do a DHS and D-rotation screw. But if you're going to be meticulous, if the fracture is very close to subcapital, People say if you do a kinetic screw, you get better 3-point purchase. The threads will be crossing the fracture site instead of being through the fracture site here. So it's got some slight advantage. However, if the fracture is really low, basicervical, or if it's a Powell fracture, like a vertical fracture, kind of a shear fracture, a plate on the side is better. And there's some evidence suggests that. So a DHS or FNS system. But again, the quality of reduction is what matters. This is what we discussed earlier, the ABC pelvis. Again, this is a medical emergency. You should show them that you are really worried. I'm really concerned. This is an unstable, high energy trauma, ATLS. And how did you know that? There is widening of the symphysis, more than 2.5 centimeters, because this is when the ligament starts to fail. 2.5 centimeters or less are normal. More than that, there is asymmetry of the pelvic ring. There is a proximal migration. There is dislocation of the sacroiliac joint. So this is the strongest joint and strongest ligament in the body. If you dislocate it, this is bad news. Okay, the pelvic is a ring, so you should look for other injuries. And this is just an outline. You see these ligaments, even with this picture, it looks like a really tough ligaments. You've got the symphysis pubis, you've got the sacrotuberous and the sacrospinous ligaments, and you've got the SI ligaments. These are very strong. You've got also the iliolumbar ligaments, so you can look for the fifth lumbar vertebrae here. If there's fracture of the transverse process, give you extra points. And don't forget they might have some other proximal femur fractures as well. Again, as we said, it's a polar ring theory. So you can't break the pelvis at one point. It has to break at 2 points minimum. So always look for the other part that is fractured. Again, you can open it like a book, APC compressions. Don't worry about the subtypes. You can compress it from the side, lateral compression. You have a vertical shear, or you have a combined mechanism where it have got multiple of both. The really one that patient dies from is the AP compression and the vertical shear. Again, ATLS, again, A, B, C, D, E, and you worry about the C. This is where you want to stop hemorrhage by closing the pelvis, applying pelvic binder. You can bring the legs together, tie the legs, and internally rotate. This reduces the pelvic volume. If not, consider injury retroperitoneum, consider other sources of hemodynamic instability, and then act according it. Okay. Native people freak out when they see these pictures because you don't see it very much unless you work in a trauma center. Again, the hip natively, again, this is high energy trauma. It's not like a hip replacement dislocation. It's a high energy. It's difficult to dislocate a native hip without fracturing something. So there would be always a minute fracture somewhere. Again, buzzwords. Again, this is a high energy. If it's looking like that, the femur looks short, looks pointing upwards. This is a posterior. The leg is adducted and internally rotated. If it looks awkward like that, head in the obturator. This is an anterior. Again, this is even more bad news, because probably your consultant would be worried if they see that, because it's very rare and it's difficult to reduce closed. Again, buzzword, need to document the sciatic nerve function pre and post reduction. And again, it's not like a hip replacement where you can put them on the trauma list and they get done next morning. This has to be done within 6 hours, ideally 4 hours, because you can get sciatic nerve injury, even if it's not injured, and you can get what's called chondrolysis, AVN. So the cartilage gets damaged and the AVN gets later on. So high energy ATLS, sciatic nerve, immediately 6 hours. If usually they are tough, heavy, muscular men, you need a muscle relaxant. The minimum is sedation. You can't just give them Penthrox or gas and air and do it. You will fail and you will break your back. You need muscle relaxant and maybe even a general anesthetic. So they need to discuss quite early with the resus team. If not, then you take them to theaters overnight, but you need to inform your consultant of that. You almost always need a post-reduction CT. Don't get CT pre unless you fail to reduce it closed, and then you don't know what you're doing. You can get a CT pre. But most of the time you reduce it and then get CT post. Why? To look for the fracture. There will be a fracture, either a posterior fracture, a femoral head fracture, or a tiny fragments that might need to be fished out later. Anterior is difficult, and there is no way to reduce it. You have just to pull and push and try to lever it. Sometimes you might need to do an open reduction. You might put a Schanz pin in the femur and pull against it. So it's quite difficult, and if you haven't done it before, don't mention how you would do it. Again, how you do it, similar to Ledbetter maneuver. Again, you put traction. Again, you have to flex the hip really beyond 90 degrees, adduct, internally rotate, and then pull. The table has to go really low, and you have to get a very strong assistant putting his hand or maybe sitting on the pelvis to stop it from moving. And then you have to put a forcible sustained pressure. And then you internally and externally rotate the leg till you manage to get it across the acetabulum, and then you extend it. And after you do that, you do an MUA gently to test for stability, and you send the patient for a CT. And once they wake up, you check for the sciatic nerve. This is a completely different, again, see, this is the difference between a native and a hip replacement. A native will fracture. You see this, if they show this, this is called the seagull wing fracture. The posterior wall is fractured. And this will need fixation later on. This one, on the contrary, is not a high energy trauma. I mean, it can be a little old lady tripped down the bathroom and dislocated the hip. Again, she may have other injuries. She may have fractured her spine, fractured head injury. So don't say I will do ATLS. You say, assuming this is an isolated injury, I would X, Y, and Z and assess locally, okay? Because this can happen really easily. It doesn't need high energy trauma. And ideally, you should do it within hours, but if they have to wait till the next day, that's fine, as long as there is no sciatic nerve injury and there's no skin compromise and patient is comfortable. Periprosthetic, me personally, I think it's a bit beyond ST3, but it's getting more common now. So we this is the slide before last, so we're just going to finish in a minute or so. Again, over 60s, you should treat again as NOF femur fracture, but realistically, most of those patients would not be ready to go to theater within 36 hours because you would need an experienced hip surgeon to do the operation. Most of the time, they are quite fitter than most people, but again, you can get them in a very elderly, unfit patient, and sometimes they may not be even to operate on them. And again, don't get too technical. You can either fix it or replace it. Fix it, you put a big plate and lots of cables. Revise it, you put a long uncemented stem or a long cemented stem, but it's a quite major, massive operation. Vancouver classification, basically, again, you can fracture the trochanters. This can be left conservatively. You can fracture around the stem. Again, if the stem is stable, you fix it. If the stem is unstable, you revise it. If you fix it, if you fracture it below, that's Vancouver C. And again, you can treat it as just a normal femur fracture, but with a stem around it. Pathological lesions, again, it can be common. And whenever you see a lesion in a bone, it's metastasis. Okay, why? Because it's the commonest lesion you will see in the bone. But again, you have to ask yourself, could it be a primary? And what do you mean by primary? Either a myeloma or a sarcoma, because this is what you will get in a bone. And then you describe it by 4 points. Where is the lesion? So you said this is a lesion in the proximal femur, upper third, lower third, subtrochanteric. What is a lesion? So how big is it? Shape, size, number. And then what is the lesion doing to the bone? Is it eating the bone? Is it sclerosing the bone? Is it mixed? Does it have an extension outside the bone? Is there a pathological fracture associated? And then what is the bone trying to do? Is there a periosteal reaction? Is there a thickening? So just these 4 points and have a structure of saying it. Both didn't leave you alone. There is a post-MBD, metastatic bone disease. Again, this patient should be investigated and discussed with a tertiary sarcoma center within 72 hours. If you think it is a sarcoma or a primary bone tumor, okay? And what would the center do? Not magic. They will biopsy it. They have to biopsy it, okay? So what would you do in a patient like that? You should investigate as an MBD, so metastatic bone disease, so FBC, UNE, LFTs, calcium, bone profile, PSA in men only, and myeloma screen in everybody. You get X-rays, AP and lateral for the whole bone, so long bone femur, and a CT tap, chest, abdo-pelvis, within 24 hours. So this is the spiel that you would say for every single patient. If there is no evidence of primary, then you think, could it be a myeloma? Could it be a sarcoma? And then you have to discuss, okay? If it's an MBD and there's lots of metastasis elsewhere, that's fine. You don't need to discuss, but you discuss it with the local acute oncology. The exception, if it's a solitary bone metastasis, there's a primary and there's only one single metastasis. You have to discuss it. Why? Because it can be a curative operation, not a palliative. They can resect it. Instead of nailing it, you can resect it. So you have to discuss it. Again, it should be a multidisciplinary. You should consider neoadjuvant therapy, pre-embolization in renal. Uh, Whenever you fix it or replace it, it should outlast the lifetime of patients. So you should have a prognosis. Patient will live 5 years, 10 years. You should do something that outlasts 10, 5 years. You just don't do a simple operation and then it will fail next year. That's why they suggest to use robust implants. You use curettage, you put cement augmentation to replace any bone loss, and you should allow the patient to immediate weight bear. Patient is palliative operation. They don't have got much to live. They should be allowed to weight bear. Remember high incidence of VTE, so you should put prophylaxis. And again, if it fails, for any reason, you should discuss it with the tertiary center. Okay. Hip arthritis, again, I don't think it's within the ST3 realm, but can ask you. Again, don't get too concerned. I mean, I've seen lots of people confusing this with neck of femur fracture. They say, oh, there's a femoral head fracture. I mean, this is a squashed ping pong ball. This is an AVN of the femoral head. You say there is subcondylar sclerosis, massive cyst, there is a crescent sign, there's a proximal migration. This is severe arthritis of the hip with proximal migration. Okay. What you need to do, you can see serial radiograph. You see radiographs before that. No one presents for the first time. They should have previous radiographs, and then you can confirm your diagnosis. Again, history and examination. And then as a hip surgeon, elective setting, I mean, this doesn't need any acute intervention apart from like physio, analgesia, send home, and then you should see an experienced hip surgeon on an elective setting. And a hip surgeon, what would they do? Two things. Are they symptomatic enough? Are they fit enough to have surgery? So if they have symptomatic enough, so history and examination, so pain at night, painkillers, impaction on activity of daily living, expectations, etc., and fitness for surgery, comorbidities, mobility, etc. And then you optimize pre-op consent, informed consent. They can ask you about complications, what do you consent patients, VT prophylaxis, enhanced recovery, day case arthroplasty, complications, and they may ask you about GIRFT. Again, GIRFT have put this nice algorithm. You can find it on the GIRFT website. It will tell you when a patient presents to the GP with a hip arthritis, what they should do till they do the operation and discharge them, even including the implants and the ODIP rating and everything. So have a quick read of that. It should give you all what you need to know. And again, this is the last slide, I promise. So it's about what is GIRFT. So those who don't know it, it's getting it right first time. It's a program, quality improvement, to improve the outcomes of patients, but also to reduce the costs in the NHS by reducing the unwarranted variations, reducing the reoperation, the complications, use only rated implants driven by data, and learn from the best performing centers and try to copy what they do. So it's data-driven, clinical-led, best practice sharing. I hope I wasn't too boring, and I've given you a little bit of information to help you with the ST3 interview. And yeah, just keep calm and you will pass, no problem. Thank you very much.
Mohammed, thank you so much. That's really, really great. I don't think they need any more in the hip more than this. Well done.
Yeah, yeah. I mean, I don't think for ST, I think it's even beyond ST3, but
Yeah,
it's
yeah.
it's
No, but that's great. That's very great. Good. So we 8 minutes beyond the time, but not from you. We were late already, so you stick to the time. That's very good. So we'll introduce Islam and Ahmed Hassan to run the knee session. So if you can share your screen, Ahmed or Islam.
Yes, bear with me.
All right, everyone. So while Islam is trying to share the screen, we'll just start by talking about what we're going to do today. So about knee part of the interview, it has to come every year. There will be some people who get knee station in their interview. So the important bits are the anatomy, which we will show some slides of. I don't know where Islam is. And then some clinical stations. Okay. So for the anatomy, they try to make
Can you see?
Yeah.
Okay, cool.
Yeah. So for the anatomy, they try to get pictures of slides that doesn't exist anywhere. It's just similar to what you'll see in the atlases. But they have their own pictures, so it will be a bit different from what you're used to. So get familiar with different resources, including atlases, Google textbooks, or whatever, just to get familiar with the anatomy. And over the last few years, these stations has come during the interview. They will just point at 10 or 12 structures and ask you to identify, and they don't ask anything beyond that in the anatomy part. And for 10 points identification, it's usually about 1 minute or 90 seconds to get them. And if you're taking longer time, they will just try to push you to go through the other structures. So get familiar with different resources and don't just stick to one. One of the years they brought pictures from Netter's anatomy, which is very useful. It will give you the idea of the structures, but then again, in the actual interview, their stations or pictures will be different, and it's usually very vague. It's not very clear structures, but you'll get most of them at least. And if you get 8 out of 10, you'll score very good in this part. So you don't have to get every single structure, and don't get stressed about identification of each structure.
And as I mentioned, guys, in the introduction bit, so the first station in the clinical, the first many station in the clinical station is going to be anatomy based. So they will give you a scenario, and then they will ask you like how would you manage this, and then they will jump straight away to the diagram, give you 10 items to identify, and you have to go through it like literally within less than a minute. So this diagram was one of the years in my interview. It's like lateral cut section in the ankle, and they ask you to identify all the muscles. So just try to get familiar with such images, because those are the images that will come to the interview. And actually, Muhammad Khalifa pro couple of cut section in his presentation was really useful, because I had one as well in one of my interviews, the back of the hip. And excuse me, I will just mention a lot I got in my interviews, because I did the interview 4 times, so I've seen a lot. So this was another one, and it's a bit common one. It usually comes with any lower limb injury, and usually ask you to identify all the compartment muscles and neurovascular bundles and stuff. So get familiar with this. It looks busy, but you just have to go through it and just like repeat and write it down, and just if you even can draw it down in a piece of paper, that would be really useful. And this one also came to one of our colleagues, Ahmad Ashur. So this is, yeah, anterior cut section in the ankle. So those are the 3 diagrams. You have just to go through every single item, identify the muscle. It's really busy, but you have to do everything. So
Yeah.
who's going to participate?
Sorry, one more thing about the anatomy that I found very useful for my interview is identify one structure in each level as a reference point, because they can get the cut section of the upper leg, middle leg, or lower leg, and structures will be different. So identify one reference structure in each level. And then once you know that, even if it's not number one structure, you just get this one and then go through it around to identify other structures, and you will be happy if you go in any order. So you don't have to follow to identify number one structure. So yeah. Okay. Moving to the clinical now. Who's happy
Yeah,
to-
who's going to join us for the first interactive scenario? Anyone can just unmute. The
I'm happy.
couple, yeah. So, sorry, can you unmute?
I am unmuted.
So yeah, Ahmad Assam. Yeah, so yeah.
Okay.
So
So
you are not SPR on call. Your SHO called you about a patient who is 28 years old with a leg pain in the ward, and you are so busy in ED just admitting patients. So can you please tell me how would you approach this situation?
Thank you very much. So we have a 28-year-old gentleman, a patient who has got a leg pain. I need to get a full history about this patient. Why is he in the hospital? What kind of injury have they got?
Yeah, so he's been admitted during the morning shift with a tibia fracture, closed tibia fracture.
Okay, so with a closed tibial fracture, my main concern will be a compartment syndrome of the leg. So I need to follow post guidelines for management of compartment syndrome. I need to make sure that this patient has been assessed as per ACLS. I need to go and see them. We'll take a full detailed history from the patient, from the admission notes, from the anesthetic notes and drug charts. Again, my main concern will be compartment syndrome. Following post guidelines, we need to split any circumferential bandage to skin. We'll elevate the limb, and then we'll make sure that they have taken painkillers. Then my main examination will be assessing neurovascular status, assessing for pain on passive stretch, pain on passive stretch, and pain out of proportion to the site of the injury. We need to make sure that they have enough painkillers, and we'll reassess them after half an hour as per post guidelines.
All right, sir. Can you please tell me how would you assess the neurovascular?
The neurovascular status of the leg will be assessed through assessing the sensory and motor component of superficial peroneal nerve, deep peroneal nerve, and tibial nerve. Superficial peroneal nerve will be assessed through sensation of the dorsum of the foot, except the first rib space, which is the deep peroneal nerve, and motor function will be assessing the lateral compartment by asking the patient to externally rotate or push my hand if I'm putting my hand through his lateral part of the foot. Deep peroneal nerve will ask the patient to dorsiflex the foot, and tibial nerve by assessing sensation over the plantar aspect of the foot and to do plantar flexion. And then I will assess the dorsalis pedis artery and posterior tibial artery.
So yeah, after 30 minutes, you reassess the patient and he's still in agonizing pain. So what would you do?
So this is clinically a compartment syndrome. So this was just an orthopedic emergency. I need to escalate that urgently to my consultant, the anesthetic consultant, theater team. We'll make sure that this patient is marked and consented for decompressive fasciotomy plus minus external fixation of his fracture.
Okay, cool. Would your practice change if this patient is unconscious?
If this patient is unconscious, I will not be able to take a history from the patient. I will not be able to assess the patient. So if I'm concerned about compartment syndrome, I need to do compartment pressure monitoring, looking at an absolute measurement of more than 40 or within 30 of the diastolic pressure, which is a delta pressure. The consent form will be changed as well. Will need to be consent form 4.
All right, yeah, that's very good. Thank you so much, Ahmed. So yeah, regarding the feedback, so Ahmed, can you tell me?
Yeah, so one of the things they like about this station is that you'll say to the SHO to start primary measures before you go to see the patients, because this shows that you're being very concerned about this patient. So you'll do the same, but you'll ask the SHO to elevate, give painkillers, ask about what painkillers the patient has taken, and then release any circumferential dressing. And then you will say, I will go to see the patient, or ask the SHO to do this while I'm getting to see the patient. And this shows them you're really concerned about this and you're starting actively managing this patient earlier. Otherwise, the measurement of the compartment pressure is, yeah, you've mentioned it right. And the management also for the neurovascular examination, you need to be a bit to the point. So instead of enumerating the nerves, and then mentioning how you will examine them, they are going to stop you 100%. So that's the other thing about the actual interview. They don't let you finish. So if you're going to say something, just go to the point. Say, I'll do superficial peroneal in this area, deep peroneal, like superficial peroneal, dorsum of the foot, deep peroneal, first rib space, tibial nerve, sole of the foot or back of the leg. And moving the leg while the patient has tibial fracture would be a bit difficult. So it's usually done by sensation and clinical examination. Otherwise, I think you don't have any problems with this, but I think these points will make them give you 5 instead of 4, which is what you're aiming for. Because if you score 4 in a station, this means you've mentioned everything right, but 5 means that you've mentioned everything right in a very nice order, and the way of thinking is better. So that's mainly about compartment syndrome. And then the fasciotomy, you'll say about the planning of the surgery. These are the lines of fasciotomy incision. I'll release the medial, the anterior and lateral compartments through the lateral incision, and the deep and superficial posterior through the medial incision, and structures at risk in each of them. So if you mention these, it won't take you more than 30 seconds. So that's the main thing about the clinical station, that you need to be to the point. You have one chance to say the answer, and you're not going to think about it. And you don't need like extensive in details description of the surgery or your approach. Just the important points, like Muhammad Khalifa said, structures at risk, the plane and the skin incision, these kind of things. If you say these, they will score you will score well, even if you miss few other parts. Yeah, so that's it regarding the compartment syndrome. It's a common station. You can get compartment syndrome in any part of the body. Last year, I got compartment syndrome in the forearm, which is another fair question, to be honest. So just get familiarized with all the incisions of the compartment of different limbs, and that will be it.
Yeah, so for me it was really good. I like the answer. I like the structure. It was really nice, just guided by the BOS guidelines. Those are the BOS guidelines for compartment syndrome, guys. You have to keep yourself familiarized with all the BOS guidelines. I believe Khalifa in the previous presentation as well brought a couple of very nice and good ones, including best practice tariff, GERFT, and BOS guidelines for metastatic bone disease, which is one of the new ones as well. And it came to one of my interviews. I've got like a feedback regarding it. So please have a look at the new guidelines and get familiar with that. It seems, Ahmed, that you have read it. You have read it a couple of times. You are quite aware. Also, Ahmed Hassan mentioned a fair point, which is going through the things as long as you know. Just don't wait for them to ask you what you're gonna do, or what's your next step is. I think it's easier for the examiner just to put their head back and give you the marks. It's really, really very boring if you just put yourself in the examiner's seat. Imagine you asking the same question for like 30, 40 people during the day. It's very, very boring. So whenever the examiner finds someone who's just like saying everything like in a nice approach, in a stepwise approach, they just put their head back and give you the fives. And this is a difference between 5 and 4. And believe me, it's a big difference, because if you get like 4 in every one of the 5 aspects from 2 different examiners, this means you're getting 40 out of 50, which is a borderline to get a job. So you have to aim for fives. To get fives, you have to excel it. Like you have to smash it. Just like go through everything in a stepwise approach, mention all the guidelines, be prepared. So one more thing is like compartment syndrome doesn't come on its own as a clinical session. We just started with it because it's really important, and I can't remember any interview in the last couple of years with no compartment syndrome. So like it's always in the clinical station. It's always part of other clinical scenarios, but they just guide you to go through compartment syndrome and to mention the BOS guidelines and how would you do the fasciotomy as well. And I think like Ahmed as well, he mentioned about forearm fasciotomy, and the last question was about approach to forearm fasciotomy. So have a look at this, guys, as well. Um, so this is a bit in the both guidelines and how to assess an unconscious patient. Just have a look at, well, this they might ask it because it wasn't there for the last year. It's just been added in June this year. So there might be a reason they're adding it. So just yeah, worth having a look, and it might come to your interview. So next one, who's willing to do it?
I can do it.
What's your name? Sorry.
Muhammad.
Muhammad, yeah. So you're orthopedic registrar in clinic. You have a 78 years old lady with significant ongoing knee pain coming to your clinic. So tell me, how would you approach this? Like, how would you start with her?
First of all, it is a 78-year-old patient with significant ongoing pain. I will start speaking to the lady, getting a history. The major things I need to take from the history: when did this pain start, and what is the honest of it, if it's progressive or not, and how much is the pain itself. The first thing I don't need to miss, I don't need to miss infection. Additionally, I don't want to miss any kind of trauma or malignancy to the bone itself. So we'll start by taking history, examining the lady, examining the knee, make sure that the knee is stable. I will check for any kind of hotness, swelling, or deformity. And after that, I will assess her radiologically and through doing some bloods. I
Can you
will
please
ask
tell me what you can see?
is a plain radiograph without any identifiable data showing a skeletally mature skeleton. On the AB view, there is a severely diminished lateral space on the both knees, mainly on the right knee, with a varus deformity.
Yeah. Okay. So then, what would you do?
So it's severe osteoarthritis at this stage. So the first thing, I don't want to miss any infection which can be coming over arthritic joint. So if I make sure that the patient is safe without any kind of infection, I will start this patient on analgesia to make sure that she is comfortable. And after that, the patient will be seen in our elective knee clinic.
Yeah. Okay. Are you aware about any approaches for total knee replacement?
I'm familiar with the medium parapatellar approach for the knee replacement. When we go about cavity incision, about straight incision over the patella, then so I can't remember the approach very well to demonstrate it now.
Yeah, definitely. So you've seen this lady. So you've done total knee replacement for this lady, and then you've seen her in the ward round the following day. What's the things are you going to look at in the first day post-op?
For the first day, post-op is quite important not to miss any surgical or medical emergency. I will check the wound to make sure that there is no superficial infection or there is no oozy wound, which is very common after knee replacement. Also, I will make sure that it is examined to exclude any signs or symptoms of DVT. And the main important, they will ask the physio for exercise, and they will ask the lady to move on. Usually during my practice, I make sure that they have full extension first day post-op, and I advise for range of movement.
Okay, yeah, so yeah, let's go for feedback.
Okay, so it seems like you've seen this before. You've dealt with knee osteoarthritis before. But before showing you the X-ray, you're a bit concerned about septic arthritis, which is a good, fair point that you should exclude septic arthritis. But about situational awareness, the question said you are in the clinic and the patient came with knee pain. It's good to mention that you will exclude infection, but just say it once. Don't make it the main concern, because the interviewers were not like this. The other thing you mentioned that it's in varus deformity, it's in valgus, and this was a question in one of the years before. What's the coronal plane deformity? So if you're not sure about the deformity, don't mention it. But if you say it, you should say the right deformity. Your answer was good, but it just a bit slow. So usually what they do, they don't let you finish everything you want to say. So if they find that you're talking about septic arthritis and exclusion of infection and so on, if you say it once, that's all right. If you say it more than one time, they will interrupt you, and then it will be disturbing for the whole station. The other thing, this patient has also osteoarthritis of the left side, and you can see the osteophyte on the medial side. For the management of this patient, you should always go through the conservative options and then surgery and with the surgery in this, just mention that there is valgus deformity, we might need to do something about it. There is a lot of options. You might need to get long leg X-ray. There are a lot of investigations and options you might do, but it's not for the interview. You just need to say that I can see there is coronal plane deformity that might need to be assessed preoperatively, and intraoperatively we might need to do something other than just total knee replacement. We might need to do osteotomy or planning of the prosthesis we're going to do.
Yeah, Ahmed. So yeah, I completely agree. So specifically with the point that you are SPR in the clinic, you guys have to pay much attention to the question itself. Don't answer another question. So I told you that this patient came to the clinic, and you spent around like 30 seconds, 40 seconds talking about like excluding infection. Yeah, it's good just to mention it once, as Ahmed said, but you just like don't go like in details of that, because like that it's a scenario of a knee osteoarthritis and patient coming to your clinic. So and you have to talk about it. And the reason why I brought this, it might sound as a FRCS level, but believe me, it just came in one of the years to one of our colleagues. So knee osteoarthritis, and at this year we didn't expect that they are going to ask about it, and like he misinterpreted this at the beginning as a knee dislocation, and he thought that they are just tricking him. So guys, like the competition is going very, very high every single year, and it's just trying to differentiate. So at the moment they are trying to bring, I won't say an FRCS level questions, but at least like a more advanced questions. It's not going to be very basic as it used to be. So just be prepared for more advanced question, or if you have any more advanced knowledge, just try to put it up there for the examiners, just to stand out from other candidates. So I think, yeah. So I would have the same comment as Ahmed. So you should pay attention to the question, where you are, where is the clinical setting, and then just use it. And also as well, yeah. If you're not sure about the deformity, just don't mention it. You might just like get away or escape. They might forget to ask you or whatsoever. But if you mentioned it wrong, this is just like you're going to lose marks, like, and it's not going to be a good science, like, because if you start your question with a big mistake, this is gone for the rest of the station. So try to pay attention to that. One more thing is like nice guidelines, guys. So I believe Mamdouh stressed on that in the introductory session. Khalifa stressed on that in all his cases. It's all supported with guidelines. So there are nice guidelines, which is like big, and everyone knows about it, for hip osteoarthritis and for knee osteoarthritis. Get familiar with that. Start with non-conservative measures, exhaust all of them. So you have to mention that in history as well. And I have my own approach dealing with all elective stations if they come in the interview. Just stick to history, examination, investigation, management. So go through history, ask about presenting complaint, analyze it, and then for hip and knee osteoarthritis, ask about like all the non-operative measures. Have you tried any painkillers before? Have you tried physiotherapy? Has she tried physiotherapy before? Any injections before? When was the last injections? How many times? Those are the things, if you mention, it will give the examiner this kind of insight that you are doing this day in, day out. So this is regarding knee osteoarthritis. You have to get familiar with NICE guidelines. What are the non-operative measures? And also it's like, yeah, you should know about the total knee replacement approach, because in my hospital now, some of the core trainees who are CT2s get some elective lists, and they tend to do or assist at least in total hips and total knees. And this is happening, I believe, across all the country. So this is happening for a reason. They will ask them about this in the interview. Just get familiar with it. So yeah, this is a bit of things about the. Who's doing the next, please? Anyone?
Islam, you have some hands up if you just see if...
So yeah, anyone wants to ask anything? Because I'm sharing screen, so I can see. Sorry. So if anyone wants to ask anything, just like
Yeah, guys.
unmute and ask.
Yeah.
Yeah,
Who's that, please? Your name?
Yeah, it's me, Mohammed Shell. I'm just if we go back to the first slide, the questions come to for the knee osteoarthritis station. The main question about the knee pain. So I think it would be a good practice if we start with analysis the concern of the patient, which is the knee pain. If we can start to analyze the pain itself, but what make it worse, what is alleviate the pain, where it refer, is it fixed, if it's constant, if there is night symptoms, how long has been there. So I think it is should be the first step in constructive answer.
Yeah, sorry, I'm not sure if you missed my explanation. I said I stick to an approach which is history, examination, investigation, and then management. So in history, I analyze the complaint. I don't ignore the complaint. So patient comes with knee pain. So how long has it been there for? Is it getting better, getting worse? What makes it better? What makes it worse? Anything? Did she try anything? I will just say that to examiner. So I will just see this lady, ask her for how long has this pain there for? Is there anything improving it or making it worse? Has she tried any painkillers? What painkillers she tried? Any physiotherapy? Any injections? How many injections? When was last one? So I will ask about everything and then jump to the other things which are comorbidities, past medical history, because like I have to ask as well about like if there is any autoimmune disease, any rheumatoid arthritis, especially in a valgus knee. Is she taking any medications, blood thinners, any rheumatoid medications as well? Because we have to optimize that before doing any surgery, and then so and so. So I have my own approach. I stick to it. I just go through it every single time with any case, no matter what. So this is the reason why I brought this in the presentation, because it came before. No one would think that knee osteoarthritis, or as Khalifa mentioned, like it's not necessarily they bring like hip osteoarthritis. But I had myself a hip osteoarthritis in one of the interviews, and he was right. Some people misinterpreted this as neck of femur fractures. So be open-minded that everything can come to the interview. It's like get well prepared, and just like have an approach and stick to it. Does that answer your question?
It wasn't a question, it's just a note. Thank
Okay,
you.
that's fine. Thank you so much for that. Yeah, thanks. So anyone wants to do the next one? Guys, it's an opportunity just to do
I
it.
can
Like
do.
no one
Happy
will
to stand
judge
if
you.
there is
Just
no
like,
one.
Yeah.
believe me, the interview is going to be much more stressful. So just like, yeah. What's your name? Sorry?
Ahmed.
Ahmed. Yeah. So you are orthopedic registrar on call in a DGH call to see 23 a male patient after RTC. So the ambulance brought them to your DGH. So can you please tell me how would you approach this situation?
All right, so this is a scenario of a high energy trauma. I want to make sure the available team is the appropriate team. I want to make sure an ATLS approach is done for this patient. A trauma call is put out for this patient as well. And the patient is approached in an ABCD manner.
Yeah, so basically he was complaining of a knee pain, and this was X-ray. So you've done the ATLS, you didn't find anything else, and the ED registrar showed you this X-ray. So can you please describe and tell me what would you do next?
All right, so this is an AP radiograph of a skeletally mature patient with non-identifiable data. The most obvious finding is of a knee dislocation. For completeness, I want to get orthogonal views. So I want to get a lateral AP X-ray I want to assess this patient, particularly his neurovascular status. I want to feel for his dorsalis pedis pulse, capillary refill, tibialis posterior. If I'm concerned, I would need to call vascular if they're present in the
So yeah,
DGH.
you can't feel the dorsalis pedis.
Okay. And for the rest of the neurological status, I want to assess his common peroneal nerve with its branches and the tibial nerve as well, both sensory and motor components, but mainly sensory as this would be painful for the patient to test the motor components.
Would you do anything before calling vascular surgeons?
So if I'm concerned about the vascular status, then I need to get the Doppler. I need to either, depending on the availability, do an ankle brachial index, ABPI, or get a CT angiogram. I'd need to assess the skin condition as well around the knee, looking out for a dimple sign, which may show that it may be difficult to relocate this in A&E. I'd need to escalate this to my consultant as well to make him aware.
Anything else you would do?
So once I get a lateral view as well for completeness, this will give me a better idea on the direction of dislocation, and I would need to arrange for urgent reduction in A&E under conscious sedation.
That's really important to do. Okay, that's fine. So you try to reduce it. It's quite unstable. So every time you reduce it, it just pop out back. So what would you do next?
So next, as I said, I'll need to escalate this to my consultant, discussing with him the possibility of taking this patient to theater to put a spanning external fixator over this knee to stabilize it.
Yeah, cool. That's fine. Anything else you want to add?
And following any manipulation or reduction, I need to reassess the neurovascular status as well.
Yeah, would you arrange any other scans for this patient after X-ray?
Yeah, so once the patient is more stable, I then need to arrange for an MRI to assess for the soft tissue integrity, particularly the ligaments around the knee.
And you mentioned something about CT angiogram, didn't you?
Yes. So if I have any concerns regarding the vascular status, I need to get a CT angiogram.
Yeah, are you aware about any guidelines mentioning that?
There is a BOST guideline for the patients with knee dislocations.
Okay, and yeah, okay, that's fine. So if it is back in ED and you put it in a back slab, what would you do?
But I'd still
So
admit
back
this
stable
patient.
in a back slab, would you send the patient home?
No, I'd still admit this patient overnight for observations as they may have an intimal tear of their popliteal artery, which needs monitoring overnight. And then again, if I have any concerns overnight, I'd then get the CT angiogram and speak to vascular.
All right, yeah, so I will leave the feedback for Ahmed. So
Yeah, I think your answer is good, but we haven't seen this patient very often in clinical practice, I mean. So I've only seen 2 knee dislocations. So the first thing, you need to reduce the knee. That's your main concern. And the reason why I brought this image is because there is a rotational element. I know you can see as well on the lateral, but even with just the anteroposterior X-ray, you can see there is a rotational element. And if the femoral condyle looks undisplaced, so you can just mention that if it's buttonholing through the muscle, this indicates that it will be difficult to reduce. So you can anticipate early, tell the patient, inform your consultant, inform everyone that we might need to take the patient to theater to get it reduced if there is rotational element, because sometimes you get the medial femoral condyle buttonholing through the muscle and you will not be able to reduce it closed. So if you mention this, that would be a very good point, and they will like you straight away that you know how to anticipate problems. So that's one thing. The other thing, after reduction, you don't say I would do ABPI or CT angio, because I've seen 2 cases, and both of them had good distal pulsation, and then one of them went to uncompartment syndrome. So you don't rely on distal pulsation. You check the ankle brachial pressure index, but most likely in practice, people just go straight to CT angio to check the peroneal vessels. And then in theater, you said you reduce the patient, put in a back slab. It's good to mention that you put a back slab in 20 degrees flexion, because if you put the patient in a cast in full extension, it will dislocate again. The other thing is when you take the patient to theater, you would assume that you would mention that this patient, if he has vascular injury, then that's the sequence we're going to follow. So vascular will start by temporary shunt, and then you put the X-fix, and then you will do the definitive bypass, and then you would do fasciotomy, or you will do fasciotomy, and then later you will do the MRI to assess the soft tissue and reconstruction. You did well in the station, but there were a few more things that the
Yeah,
examiners want to listen.
I believe you just want to be more organized, and as I mentioned before, you just like need to be slick, just like very quick, mention everything in a stepwise approach. I will see this patient. I will examine him as per ATLS protocol. Assume that this is isolated injury, closed, because you mentioned later that you will check integrity, just mentioning it in the beginning. Closed, isolated injury, neurovascularly intact. This is an orthopedic emergency. I need to reduce this joint as soon as possible. Just bring it out like at the beginning, at the top. It's like you waited until like the 3rd minute to mention that you're going to reduce a knee dislocation, which is like not reassuring point for the consultant who is interviewing you. Because believe me, the consultant who is going to interview you guys like is just like picking their own future registrars. They just want to pick someone who's safe, that can run the on calls while they are at home, if you know what I mean. So it's like I remember one of the feedbacks for one of our colleagues. The consultant mentioned to her that she is very safe, and like I will feel very safe for her to be my orthopedic registrar, so on call. So they're just like picking a colleague, a junior colleague who's going to work with them. So they want you to be safe and to be like very switched on and know what you're saying and what you're going to do. So it just need a bit of organization. You know everything. You know the guidelines. You know what you're going to do. You know how you're going to deal with it. You know you're going to involve vascular. You're going to fix. You're going to involve the consultant. But the way you answer the question is a bit unorganized, if you know what I mean. So it just need a bit of organization, and this won't just come like overnight. You just need practice and practice and practice. So that's why practice is much more important than anything else. So yeah, I would just suggest like work on your answers, write it down, and repeat it. But you basically mentioned everything, but like
Not
no,
structured.
that's it. Yeah. So get structure, and get your answer like very slick and rehearse it. So yeah, that's it. And also mention the important things first. This is an orthopedic emergency. I will deal with it by doing so, especially with joint reductions, native joint reductions. You need to reduce them as soon as possible.
Okay, thank
All
you.
right. That's it. There was a question in the chat. I just had a look. If it comes to DGH, you have to deal with it. So you can just like send, especially if there is a vascular problem, at least do a CT angio. And this happened like to me once. So you have to arrange a CT angio for the patient. You have to buy an X-fix for the patient. You can just send the patient out of the hospital with a knee dislocated and a vascular problem. Okay.
Yeah.
Any other questions for this?
Yeah, Mamdouh is raising his hand. So yeah, up to you,
yeah.
Mamdouh.
Want to give thank you everyone for this great effort. To be honest, it's lovely presentations and lovely cases. I just want to mention a small advice for the candidates and colleagues. Whenever you answer a question, you have to change your voice tone, as Islam was saying. Oh, this isn't a case of emergency. I need to assess this patient as soon as possible because knee dislocation have a higher incidence of vascular injury, which can affect limb threatening. So this shows how you respond in a similar situation. It's not like if I give you a case of undisplaced medial malleolus, then I will go to see this patient. This is a small advice for the candidates who are going for the interview. You need to control your voice tone to show a reaction to the examiner.
Yeah, that's
Yeah.
actually very useful because me myself in my first interview, I didn't care about the tone of my voice and I was very monotonous. But then in the second, like later when I took the interview, I worked on this and I did better. I scored better, even without changing much, but just by changing the tone and giving them that impression that you're concerned about this patient, they will like it and they will score you better just for this. Yeah.
Yeah,
Thanks.
guys. Also, like, put yourself on the examiner seat. It's very boring. So you have to do something just like to stand out. Because, like, imagine they are like listening to the same answer from 40 candidates like during the day. It's very, very boring. Everyone is going to do the same, is going to talk about the same shit, ATLS, closed isolated injury, neurovascularly intact. So everyone is going to say same things. Like don't think that you're just saying like something different. Everything is going to do. Everyone is going to do the same. So you have to stand out. So it's like those are the little things that might just like put you ahead of other candidates. So who's doing the next one? I know we are running a bit late, but
Yeah.
I hope you're enjoying, guys, and getting like useful
Hi.
feedback.
If there's another scenario, I'm happy to go for it.
What's your name? Sorry.
Muhammad.
Okay, Muhammad.
Islam,
So you,
just a minute. So Muhammad Shael, do you have another question or just a legacy hand?
No, excuse me, just more point in the last case. According to post guideline, we need to highlight that all this patient with knee dislocation need to do ABI index after reduction. It's mandatory, even if we feel the distal pulse, and if it's less than 0.9, we need to go for CT angio plus urgent vascular consultation. If it's more than 0.9, it's all right to keep the patient in ward for distal vascular observation overnight.
yeah. I'm so
Yeah.
sorry I didn't bring the post guidelines here, but yeah, worth checking, guys. So just go for the post guidelines website and have a look. Muhammad, are you ready?
Sorry, Islam, but there is no poster guidelines for knee dislocations.
It's for arterial injury, not for knee dislocation.
Yeah, for arterial injury.
Yeah.
Thanks.
Muhammad, you are orthopedic registrar on call. You call to see a 65-year-old male patient with ongoing knee wound discharge after TKR.
Okay.
Can you please describe the picture and tell me how would you approach this?
Yeah, so this is the clinical photograph of an anterior knee. I don't have any patient demographics. I can see there is yellowish discharge coming out of this anterior middle of the anterior knee wound, showing some pus as well. So I'm quite worried about septic arthritis in this patient. I would attend this patient as soon as possible if I don't have any other more emergencies. Otherwise, I'll ask my SHO to go and review quicker. But in that context, I would see the patient from a septic arthritis point of view. I would assess the patient as per the CRIS protocol to exclude any life-threatening injuries. Assess the patient, including full history, going through the operative notes, when was the surgery done, and any intraoperative or postoperative complications. I would assess the patient hemodynamic status, namely assessing the blood pressure, heart rate, MAP, and I would assess if the patient had any recent bloods. I would look through them, looking most importantly through the inflammatory markers. Assess the patient clinically as well, asking about the pain symptoms, if the patient has been feeling unwell, and assess locally for signs of septic arthritis like swelling. I can see there's a discharge already, assess the range of movement, and I would also assess and document the neurological and vascular status and details, motor and sensory components of tibial, superficial, deep peroneal, and the vascular status of that limb. Then I would, given that this is a knee replacement, I'm worried about septic arthritis. Any aspiration cannot be done on the ward. It has to be done within a theater setting. So I'll ensure the patient is being kept nail by mouth. I would liaise with theaters and CPOD urgent anesthetic assessment. I'd escalate to my consultant regarding this patient needing an aspiration plus or minus DAE and washout. If this has been within the context of the last 3 weeks, and sending samples to the lab and discussing within the next infection meeting.
Yeah. Okay. So are you aware about any guidelines?
There's BGI BOST guidelines for prosthetic joint infection that I would be following this for. Yeah.
Okay, cool. So yeah, it's like I would have the same comment. It's like you know everything, but it's like yeah, you just have to bring it up. It's like sometimes the examiner won't ask you, are you aware about guidelines or not? They will just
Yeah,
like
of course.
tick you in the mark sheets like 3 out of 5, and just like shit comments like yeah, he didn't mention anything about both guidelines. Although you mentioned everything, you know, so you know everything, you've gone through everything, but it's just like one simple word, like those buzzwords, guys, they like it. It's like MDT. They like MDT. It's like they love to hear it, like arthroplasty, MDT. It's like yeah, they love to hear it. That's it. You mentioned that you will discuss it, but it's like arthroplasty, MDT, complex arthroplasty, infection, MDT. Like those kind of things, they love to hear it. Both guidelines. There is both guidelines, so it's like and it's recent as well. It's just like less than 2 years now, or nearly 2 years. It's like you guys have a go through it. It's like dealing with prosthetic joint infection, and I would mention prosthetic joint infection rather than aseptic arthritis because it's specific. You know that there is a total knee replacement inside there. I told you that this patient had a recent total knee replacement. Also in history, I would focus about the index procedure. I will ask when was the surgery done, who did it, where, which hospital, and was there any problem after the procedure or not, according to the post guidelines, because this is mentioned clearly in the post guidelines. You have to ask about index procedure, who did it, when was it done, where was it done, and was there any problem with the wound after the index procedure or not. You are right about assessing range of motion, hotness, redness, this kind of stuff. There is a discharge. You can send a swab as well. You won't start antibiotic. I know you won't, but you didn't mention that. Unless the patient is septic. This is as per post as well. You will keep the patient fasted, discuss all the options with your consultant, and inform anesthetists and everyone, and keep an eye on this patient overnight. So again, you know everything, but you just like need to like get the structure more and more slicker as well, because this is going to be just 5 minutes mark. I think you spent around like 4 or 5 minutes and you didn't cover everything, or you didn't. There will be like other questions with it. It won't be just how would you manage. They will ask you about the anatomy question or any approach or anything. So this is just like a 2.5 minutes question. So you
Again,
spend double the time.
I would just mention two very important things. Situational awareness, which seems to be some people are missing. So this is an infected total knee replacement. It's mentioned in the question. So your answer should be directed to infected total knee replacement, not infected joint or infected.
Yeah, sure.
So that's one thing. And the other thing is key points. So in your history, you won't have a chance to mention every single thing, because otherwise they will miss what you're trying to say. And don't sound like you're trying to give the same answer for all the stations, because that's what everyone does, including myself. We just have a format and we try to stick to it to every station, but try to make your answer directed to the questions, not just like I'm going to do the same history for every single knee I see, the same history for every single hip I see. So it should be focused on certain points. So you have pus coming out of a total knee replacement. You need to know when the knee was done and how long these symptoms have been and how bad or good is the symptoms, if the patient is on treatment already on antibiotics. And then in my few hospitals I've worked in, we don't aspirate total knee in the ward. You mentioned that. So if you do that in your hospital, you should mention we do that in
Sorry, can I interrupt for 1 second?
Yes, sure.
Was I speaking a bit quickly? Because what I mentioned is I would assess when was the knee done, how long has been the symptoms done, and the other thing, I wouldn't aspirate on the ward. I would do it in a controlled
Yeah,
setting.
you mentioned that you wouldn't aspirate in the word. Anyway, that's fine. So we might have missed that. Like,
No, I don't mind. I'm checking for
that's all right.
feedback rather
No,
than
that's all
commenting
right. It
whether
just
I
because
was speaking too quickly. That's all.
No, it's all right. Your like your speed was all right. It wasn't bad. I will like it was okay. So just like don't go any more slow, please.
Yeah. Okay.
Uh, I think we might have missed that you asked about when and like when and what that was operation, who did the operation. Yeah, it's all right. As long as you're aware, that's our aim. Just like we're not
Of
here to
course,
judge
yes.
anything, just like
Of course, yes.
trying to give you like a fair feedback. So
sorry, the
I
other
want you
thing
to,
is
yeah,
the
okay,
other thing,
carry
sorry,
on.
one more thing. Even if you say the answer and both of us didn't notice it, maybe the examiner will not notice it because the examiner will be more bored than us, and he's more
To be honest, yes,
senior
it
and
happened to
older than
me.
us. He's like maybe 55, 60, and he's been doing that for a few days and he's bored.
Yeah.
So
Yeah.
you just need to highlight these points that
Yeah.
Yeah, that's true. I had
everyone will hear.
I had this in one of my feedbacks, like two different feedbacks. Like one of the examiners mentioned, like I can't really remember what was it, but it was something like that. One of the examiners wrote in their feedback, he mentioned it, and the other one wrote that I didn't mention it. And I got in this domain 5 and 3. So imagine, I got like someone gave me 5 because I mentioned this, and someone gave me 3 because I didn't mention this, and you can't appeal it. That's done.
Yeah.
You will get what you will get, and that's it. Done. Move on for the next one. So
Yeah.
yeah, just try to be clear. And yeah, if it happens now, it might happen to you in the interview as well. But anyways, like as long as you're aware, we're just trying to give you a feedback.
Sorry, Dr.
Also,
Mohammed Hashim has raised his hand.
Yeah, time, guys. So, do you have any more cases to discuss? We're far beyond the time.
yeah, one more. Just like this
Yeah,
is
yeah,
an
go ahead.
important
Go
one.
ahead.
So
Just one more.
anyone is willing to take this? Anyone? Anyone want to take another case from guys who did participate before? Just a quick one.
Yeah, I can do it.
Okay, so you are speaker strong call in MTC, sorry. So a 14 male patient came with RTC. This is a clinical photograph. So can you please tell me what you see and how would you manage this patient?
So this is a clinical photograph of a patient who has an open fracture, tibial fracture. I'm making sure that I will assess this patient according to ATLS principles. Given was a trauma call and doing an ABCD and ATLS principles. So if after doing the ATLS, if it's an isolated injury, I'll make sure to stick to the both guidelines of open fractures. Given IV antibiotics within the first hour, photograph of the wound, remove any gross contaminations, cover the wound with a saline soaked gauze and occlusive dressing, and also immobilize the limb with a splint, assess neurovascular status for a compartment syndrome or vascular injury, and also early involvement of plastic surgeon. And also I should make the consultant aware of this injury if we will take him to the theaters.
All right. When is the earliest you can take him?
Sorry?
Would you take him to theater overnight?
If there is any vascular insult, and if the vascular taking him to the theater, I will take him to the theaters, yeah, overnight.
Okay, so no, vascular is intact. So when is the earliest time you take him?
If the patient came overnight, so if it's a high energy trauma, so I will take him less than 12 hours. If it's a low energy trauma, less than 24 hours.
Okay, so you're aware
And
about,
if also there is a high contamination as well.
okay, and you're aware about guidelines, yeah,
Hmm.
mentioning that.
I've mentioned, yeah, Bush guidelines for open fractures.
Yeah, as per post guidelines.
Yeah.
Okay. So this is a X-ray. Yeah, how would you plan for this patient next?
So this is an AP X-ray of a slightly mature patient with no identifiers, showing there's an evidence of displaced tibial plateau fracture. I believe it's two compartments. My key concern is the high energy trauma. Is this the same patient? This is a
So
different one.
assume it is the same patient.
Ah,
And
okay,
it's
yeah. Yeah, so my key concern is still to exclude the neurovascular injury and the compartment syndrome. And after doing the ATLS and the Bush guidelines principles, I'm going to put this patient in a back slab to mobilize his limb, and this patient I can add him to the trauma list to be discussed in the MDT meeting for a fixation.
So would you
And
fix him? Would you fix him, or like what would you do? Like, so you take him the following day with plastics, you do the debridement, and they plan just to do the flab in 3 days or so. So what would you do?
this patient will need an discussion with a reconstruction team to put him in a X-fix because there's an open fracture with high risk of infection.
Yeah,
And
cool.
then after that,
After the X-Fix, would you do anything?
yeah, this patient will need an CT as a pre-surgical planning after soft tissue has been settled.
All right, just to go through it quickly. I know we're running behind the time. So span scan plan. So it's like if you just mention it to the examiner, they know that you know about it. So those are both guidelines for open fracture, guys. So this is one of the like the biggest ones that you need to know, and it comes to interview quite it's a quite common ones. So yeah, we had another like scenario as well, was hot swollen knee joint. It comes as a scenario as well, and the most important thing here is just to mention or rule out necrotizing fasciitis, especially if the patient is IV drug user or has like an immunocompromisation like diabetes or any immunocompromised condition. So yeah, I think it's like necrotizing fasciitis is one of the trendy questions as well. And there is another brand new both guidelines talking about the musculoskeletal soft tissue infections. And the reason why I brought this as well, patellar recurrent instability or first time, because there is a brand new as well both guidelines. It might come. I'm not sure. Everything can come, guys. So just like have a look at everything. So this is both guidelines for assessment and management of first time lateral patellar dislocation. So it might come in an interview, just worth having a look and just going through it, and that's it. So we're so sorry to be behind time. Thank you.
No, that's
Can I just
great.
get a quick feedback if that's fine?
Yeah, sure. Go ahead. So yeah.
Sorry, just a very quick thing regarding the open fracture. You just mentioned split your answer into emergency management, and then when you're going to take the patient to theater, just follow the guidelines, and it will tell you. So you need to mention it without him asking. If there is vascular injury, gross contamination with sewage, agriculture, or marine contamination, and then if it's high energy, 12 hours, low energy, 24 hours. So you should mention this straight away without anyone asking.
Like
You will need.
I've asked him. I know you mentioned that in the beginning, but every time you mention you saying something mentioned in the both guidelines, refer to it. So when I ask you when will you take him, so your answer starts with as per both guidelines. I will do that. As per both, I will do that. So yeah, I know you mentioned it like in terms of antibiotics and taking photographs involving plastics, splinting and doing this kind of stuff. Yeah, this is your initial management, because your management is going to be initial in ED and then later on in theater, because also like both guidelines take you through everything until like a definitive closure. So I know you mentioned it, but I would myself just mention it every time. It's like As per post, I will do that. As per post, this means I have reference for what I'm saying, if you know what I mean.
Okay.
Yeah.
And one more thing regarding the timing of surgery. What are you going to do in surgery? That's a combined decision. That's orthoplastic decision.
This
So
is the
whether
word
you
that I wanted to hear.
yeah,
Orthoplastic.
or primary closure, it would be orthoplastic in a orthoplastic center, and the management, whether we do X-fix or primary closure or whatever, is both plastics and orthopedic decisions. Just mention this word, and you will know that how to deal with it.
Okay, just a quick one. In this type of question, clinical, can I ask if I'm in MTC or DGH? Because orthoplastics usually.
I mentioned to you in the beginning. They will tell you.
Okay.
That's why, guys, you have to pay attention what they're saying. Sometimes it's not being written in the screen, because like I remember on one of the interviews I had this hip pelvis X-ray with hip osteoarthritis, and the key was that he's mentioning you're seeing this patient in clinic. And I know some people who misinterpreted this as a neck of femur fracture. Honestly, I know them personally. So pay attention to what they're saying. And this is what Ahmed was saying about situational awareness. If you go through the applicant handbook for the interview, you will find the scoring matrix at the end of the handbook. There are, I think, like 20 or 30 points only for
Yeah.
situational awareness across all stations. So those are the things that they are looking for. Are you aware or not? So do you know what you're doing? It's like in the station that we were discussing knee osteoarthritis. If you just kept talking about septic knee in the clinic, patient comes to you to your knee clinic with a knee pain. You kept talking 2 minutes about septic arthritis, so you're not aware about what you're doing. So it's like it will score you very low, 2 or 3.
Yeah.
All right, thank you.
Good. So I think Khalifa has a comment. So please, Khalifa, if you come in.
Hi guys, just a quick comment. I think excellent station, excellent response and feedback. But again, it's just echoing what all the faculty was saying. These scenarios are not artificial, so don't try to make them artificial scenarios. So try to act like you're managing this in the ED, and remember, it's safety comes first. So, for example, Islam, when he showed this open fracture, for example. It's not an open fracture. It's not like a puncture wound. This is almost the leg half amputated. So you should say, yeah, this is a severe form of open fracture. You change your tone. I'm very concerned. This is a limb-threatening injury and a potentially life-threatening injury. I would be concerned about the soft tissue integrity, the neurovascular status, the gross contamination, excessive periostid dripping, etc. So you should show that you are really concerned. You will leave everything in your hand and you will go assess this patient first. Also, make sure you involve your consultant quite early, because this might be in the middle of the night, you might be asleep, you might be an hour away. So whenever the patient is stable and you went through the guidelines, etc., make sure you involve your consultant early. Make sure you also tell them you are aware that this patient will need theaters at some point, so the patient is starved, or at least you document when the last time he had something to eat or drink, and you starve him from now on. So this sort of things will make you stand against other candidates, because, I mean, at least I'm talking about myself. I don't have native tongue. I can't just mention lots of rubbish things and make it sound nice like the native people here. So I have to be very precise and appear very confident and also very safe. This is what you can do. And again, time is money. So and points for you in this scenario. So don't wait few seconds. I mean, I've seen every single. At least to me, it's very irritating. So when you say this is an X-ray of a skeletal immature, no identifiable data. Why do I give you identifiable data in the exam? I mean, it should be anonymous anyway. So I don't know, maybe not a fair point, but at least it irritates me. And as the faculty was saying, the examiner are switched off. They can get switched on in two scenarios. One, you say something really bright, really like music to the ears. They get switched on to give you good marks. Or you can say lots of irritating things, and they will get switched on in an aggressive way, which you don't want. You want to keep them either snoozed during the station or switched on in a good way by saying nice things, and they can even push the station to maybe more challenging questions for you.
So yes, I mean, they said it's a 40-year-old X-ray of a patient. So he's clinically mature. You can say an adult patient or a 40-year-old patient, it's clinically mature first. It's wasted time and it doesn't add any more marks. So just be aware of things. And the other thing, when you see a patient, just tell them what you think. Like a knee with a pus coming out. Okay, this is a knee replacement, pus coming out. I'm concerned that this is a prosthetic joint infection. So it took me 2 seconds, and I've told them what they want to hear about. It's a prosthetic joint infection. And then what are you concerned? You need to know how long this infection has been going on, and is this patient septic or not? If patient is septic, you go septic 6, for example. If patient is not septic, then you can deal with it in a timely fashion. And then you go with the guidelines, PGI guidelines, investigation, examination, history, etc. And have a way of acknowledging history and examination in a pointed way. So like acknowledge the shit, but don't get stuck in the shit. So don't waste 2 minutes saying, I would examine. You just need to get the salient points. What do you need to know from the history? When was the operation done? Antibiotic, previous infection, previous symptoms, etc. Comorbidities, diabetes, immune suppression, this sort of thing. And then you jump to investigation and then management. Last point, I know because we're out of time, speak like an orthopedic surgeon. So don't say words that we don't use it as an orthopedic surgeon. So a knee infection, don't say septic arthritis. We don't say septic arthritis in a prosthetic joint infection. It's PGI. Again, don't say things that you don't get to hear in trauma meetings and orthopedic surgeons. Just mention very precise wording or keep it very generic, but don't provide things. For example, the CRISP protocol. It's good. I mean, you mentioned CRISP protocol, but I would reserve it to those who are critically unwell on the wards, having like heart failure, pulmonary embolism, DPT, etc., low SAT. But a patient coming with a PGI, you worried me about sepsis. So you can mention quickly, but don't get, again, like the faculty said, don't use a template for every single case. Try to make it individualized. And believe me, this is what will make you stand against other candidates. Those who don't have experience will go through a template and will say the same thing for every single patient. Be precise, know what you're doing, and give them what they want to hear very early, very early. This is a knee dislocation. It's a limb-threatening injury. I'm worried about the vascularity, and I need to reduce this as soon as possible. And then you start. So this will set your marks high from the beginning. Thank you very much.
Thanks.
Thank you so much, Khalifa. Very well done. Good. Ahmed Islam, thank you so much. So I think we deserve a break. We are very late beyond time. So we'll make the break in 10 minutes. So we'll restart again 11:43. So with the foot and ankle. So you have 10 minutes, guys. So you can grab a cup of coffee or you just have a move. And we'll see you at 11:43 sharply because we don't have any more time to delay. Otherwise, we'll be delayed at the end. Okay?
Thank you.
All right, thank you.
Could give you an idea that this is a fracture as well. So 2 things to be aware of. I wouldn't get bogged down too much in terms of, memorizing them to the detail, but just in case. When we talk about classification, we have 2. We have the Essex Lopresti and we have the Sanders, which I would mention if they ask you for classification. So the Essex Lopresti is an extra-articular one, and it's usually 25% of the time, whereas with the second type's intra-articular, it's more than 75% of the time. Either you have a tongue type, which would be essentially something like this one, so it's a tongue type opening up, or you have a depression type. I think that's more than enough. It goes a little bit into more details of the classification, but I think that's more than enough to use. And then the Sanders, as we talked about with CT. So as with everything, the more further down you go the steps, the more severe. So non-displaced or minimally displaced. Type 2, you have 2 articular pieces. Type 3, 3 articular pieces. Type 4, 4 or more articular pieces. So essentially, it's turned to mush. Sorry if I didn't check previously if we've talked about trials, but trials are very important, and you'll find loads of them in upper limb. So tomorrow you'll talk about the ProfHer, you'll talk about the draft, and it's quite a key thing to have in mind, because these are essentially, at the end of the day, when we operate or not operate, it's all based on research, and evidence-based medicine is what we do, right? So with calcaneus, the one to know about, I think, is the UK heel fracture trial, so the UK HEFT. I wouldn't get too bogged down into knowing multi-center random control, how many patients, this and that. But if they ask you about it, it's good to say, it's a trial where it looked at patients with displaced intra-articular fractures and randomized them into two, operative versus non-operative patients. And essentially, our key indicator was the PROMS, or the primary reported outcome measure, the patient reported outcome measure, sorry. So for this one, they used the Kerr-Atkins score for pain and function at 2 years. And the conclusion was that there's no symptomatic or function advantage after 2 years between interventions, essentially operating or not. And with operations, you did have increased complication rates. Therefore, in summary, for them, operative intervention is not recommended on the basis of these results. So done and dusted. Okay. So you don't need to get bogged down into literally every step, the methods, all that stuff. So just what the actual trial was, what they were looking at, how did they measure what they were looking at, and what the results was. Moving on to Lisfranc injuries. So another one that I think is quite a high yield one. So vignette, typically you're going to have someone who's coming in with either a crush injury or axial loading with rotational injury. I don't know, someone's falling off a horse and their foot twisted, they're playing football, they turned around, their ankles got stuck in the mud as they twisted, something like that. Again, same management principles. With your X-ray, you can say this is an AP image showing AP radiograph of the foot showing, you could see a flex sign here, which we'll talk about in a second. I would like orthogonal views, including a lateral and an oblique, just to further delineate this. With the management, you want to talk about the same things again, repeating over and over. Ample history, social history, examination. You get your X-rays, images, and how you manage it. I think it's important to discuss plantar ecchymosis, or essentially get bruising on the plantar aspect of the foot. It's not always there, especially in my experience. I haven't always seen plantar ecchymosis, but it's one to say when you're doing your look feel move in your look part, you can look under the foot to see if there's signs of bruising, which could point you towards a Lisfranc. Investigations wise with Lisfranc, we do want an X-ray, and after X-ray you get a CT scan, and sometimes you might get a Lisfranc injury with no avulsion of the bony fragment, and it's purely a ligamentous injury. The CT scan on its own sometimes cannot give you enough information. If clinically the patient is still having pain after a CT, you consider doing an MRI, which could show you that the ligament is gone and the bones are still in place. Something I didn't say here, but in general terms for Lisfrancs, if you're not very sure on an AP radiograph, you can get an AP of the other side as well, and just shows weight bearing, and it just shows you whether the joint is opening up, which I'll show you a slide on this in a second. So Lisfranc ligament itself is a ligament that goes from the medial cuneiform to the base of the second metatarsal. And what it does, it stabilizes the first and second metatarsals and maintains the midfoot arch. So essentially, it's one of the strongest ligaments in the foot. And that's why we pay close attention to it when it's injured, because if it's injured and not dealt with correctly, you can get a very unstable foot. To be honest, fair game, they might ask you again in an X-ray, they'll tell you what are things you're going to be looking for in an X-ray. So on an AP, what you want to discuss is essentially you need to have a line going down from the second metatarsal down to the medial border of the intermediate cuneiform, the medial one here. So what happens, this is quite a severe Lisfranc, is because that ligament is disrupted, the joint opens up, and then once you trace down the cortex, you see you have a step here. So instead of being nice and congruent like here, it ends up being a step. So that's an AP. You mentioned I'm looking for a disruption of the joint line between the medial part of the second metatarsal and the medial part of the intermediate cuneiform. On the lateral, what you find is because the ligament is not holding the second metatarsal, you get what we call a piano step or a dorsal subluxation. So the second metatarsal ends up essentially flipping off, and you can see it here quite clearly. And then finally, on an oblique view, what you want is the medial border of the fourth metatarsal to be with the cuboid. So look at the medial border of cuboid. So quite a huge step here again. Okay. So these are all telltale signs when you're looking at a X-ray, either AP lateral oblique, that you might have a suspicion for a Lisfranc ligament injury. Moving on. So this is a patient that I saw on call on Monday, actually. So these are my images coming in, essentially diabetic foot infection. So diabetic foot infection is very fair game. Most places you think vascular deal with, but as an orthopedic registrar, especially on night on call or whatever, you need to be able to see these patients. Okay. So what I was showing here is just an ulcer that's essentially causing erythema, and sorry, poor image, but that's from my actual camera, but you can see gas bubbles underneath the skin, which is never a good sign. So essentially, diabetic foot infections should be treated very seriously, okay? And in terms of what guidelines we have the NICE guidelines for diabetic foot infection. I think it's worth a read because essentially for diabetes, you need an MDT, which I'll talk to you in a bit. In the actual vignette, you might be getting photographs, and previously you have gotten photographs, and you correctly mentioned, you say this is a clinical photograph showing the left foot of a patient taking unknown date and time, whatever. It shows very clear erythema and a discharging, an ulcer with discharging pus, and an X-ray showing this and that. Okay, so my key concerns are, I want to first exclude necrotizing fasciitis and neurovascular injury, and I'll treat this patient as per CRISP. I think that's fair game to say CRISP for this one because they usually come on well. And this guy was AKI stage 3, using 10, CRP 400, I think, glucose was 60, quite unwell. So you'd want to make sure you resuscitate them and do the rest of the things as well. History, if the patient's able to and they're not septic, you do an ample examination. So you review the observations, you review the bloods, examine the foot, you check for any tender points, swelling, crepitus. This guy had quite severe crepitus. Pulses, either feel them, and if not, you get yourself a Doppler, and you're looking for a fluctuant mass if it's discharging or not. If there's a discharging ulcer or sinus, whatever, you always say you want to take swabs. So you take a pus and a wound swab. You want to get an X-ray because, as you can see here, the X-ray gives me a lot that I need to know already. That is quite significant. Ultrasound or MRI and arterial duplex. And in the first instance, you're managing these patients. The vignette will be of someone who's quite unwell. So you want to do your sepsis 6 bundle. That's always a good one to say. And escalate if septic and requires incision and drainage urgently, essentially meaning you've done your initial resus, patient isn't getting any better. You need to go in and drain that pus. Escalate your consultant, nail by him out, get your consent, speak to the anesthetist, C-pod, the rest of it. Okay. If it's a stable patient, so not neck fash, maybe a boggy swelling that's been there, inflammatory markers are okay, patient is stable, then usually this needs to be discussed with an MDT. What incision and drainage in the presence of vascular compromise, and quite most of the time, usually diabetic feet will have vascular compromise. This should be done under vascular team and specialist center. And the reason I've pointed this out is I have a very nice algorithm here, which I'll show you in a second. But in the actual interview, if you're in a tertiary center, then you can say, we'll speak to our colleagues. If you're in a DGH, the way to be pragmatic about this is if in the first instance patient is very unwell and not fit to be transferred, then this is something I will discuss and escalate with my consultant for an initial incision and drainage or debridement. And then once patients stabilize, discuss with vascular consultants for further management. These patients could end up needing, in the most severe cases, an amputation, or if they need a revascularization, then that needs to be done by vascular.
I will just add to, yeah, perfect. You brought already the slide. I will just add to Jad's point. So diabetic foot attack is a common theme now within orthopedics and where the management should be. I mean, both us, the British Orthopedic Foot and Ankle Society, have guidelines about this as well, besides both guidelines, the one that you've mentioned. If a patient comes and they're acutely septic, even if you are in the DGH, you have to reduce the bacterial load. And the way to do that is by an emergent IND. And this needs to be quite aggressive. There are more to this, but essentially for the exam, you can say, yeah, this will require an emergent incision and drainage to decrease the bacterial load. And then if you want to quote papers, there's something called Prof. Aluaya. He's one of the diabetic foot surgeons at King's. There's a paper which mentions the traffic light system, where you say red, amber, and green. And then it's just the areas where you need to debride. This is if you really want to get into this. But diabetic foot attack is one of the emergencies that you really need to know about. It's as important to you to know, be well aware of, at least not just for the exam, for life as well, as other emergencies. I will add a link here. I've already added the link to both us in the chat, and then the principals are going now into this now. But be aware of diabetic foot attack.
Yeah, exactly. Thanks for adding that. But yeah, so I would read the BOFAS one for sure. It's a nice one to have. And, in an exam situation, a real life situation, even is what we're talking about, just don't take this lightly. Yeah. So, if they're stable, so as per NICE guidelines, every hospital should have an MDT to treat and manage ulcers, infections, ischemia, and vascular disease, as well as Charcot neuropathy. And the MDT includes a diabetologist, podiatrist, a diabetic specialist nurse, and an orthotist, essentially someone who gives them corrective footwear. Okay. As per the guidelines, patients should be reviewed within 24 hours. And the goals really are to treat infection, optimize the glycemic control, and manage the complications. So this is a small algorithm I took from one of other resources. I will mention it at the end. If it's not requiring surgical drainage, so medical team can look after them, optimize their blood glucose, ensure that they're getting the adequate management. If it's requiring surgical drainage with no vascular concerns, for the most part, you will have to do it on the orthopedic team. However, if there's vascular concerns, and that's by you trying to palpate, there's no pulses, you've done a Doppler, there's no pulses, or it's weak monophasic, then you refer urgently. And just a few more slides from me. I know this is a bit of a quick fire one, but it's just things that you will probably see in the exam. Happy to give you these slides after, but we're just going through things that you should be aware of and in your own time go into in much more detail. So BOS guidelines, we keep going around with BOS guidelines. I would suggest open the website, BOS guidelines, literally every guideline, go through it again and again and again, is what I did at least. Ankle, hip, distal raised fracture, spine, whatever it is, go through the whole thing. So just key points for ankle fracture. So the BOS guidelines suggest you need to document your mechanism of injury, neurovascular status, skin integrity, and patient's comorbidities. They say you need to get an AP, lateral, and a mortise. And if you have a suspicion for a mesonerve injury, which essentially you have a medial malfracture but no lateral mal, you need to get a proximal tibia fibula because you can have an undisplaced fracture more proximally. And as discussed earlier, so you get a CT for complex fracture patterns. So trimalleolars, somewhere you're not able to get into the joint or reduce it properly in a CT scan. So management, urgent reduction, reassess neurovascular status, document that, confirm on X-ray, document that. If it's stable, both guidelines mentioned boot and weight bearers tolerated. If you don't know about the stability, you review them within 2 weeks with weight-bearing X-rays. As we discussed, operative less than 60 years, early op, day 0 or day 1. Over 60, for the most part, close contact casting of good reduction. But again, you have to be pragmatic with these. You can have a 70-year-old who's still biking every day. You want to give him better function. Surgery aims, you're reducing the fracture, stabilizing the mortise, and you're assessing and stabilizing the syndesmosis. And post-op, you want to mobilize them in cast, put them in or a splint, depending how confident or how stable the fracture is, and you follow up in clinic within 6 weeks. That's both guidelines, but pragmatically, usually we end up seeing them earlier than that. Operations that are fair game. I'm almost done now. So you have two. You have the Weber B bimalleolar fracture ORIF, and we have the X-Fix that are usually fair game. So I'll start with in general, whenever you're having an operation, think of it as what I would do. Because remember, by the time you get to the operation in any of your scenarios, you're probably towards the end. So you have about 2 or 3 minutes tops. So you want to make sure you compartmentalize in your mind, sorry, what I've done pre-op, what I've done in the operation, and after the operation. So I think to hit full points, you'll say I would ensure a team brief was performed prior to sending for the patient, and then in an appropriately marked and consented patient, I would perform a WHO sign-in and timeout. I would make sure they're supine on a radiolucent table with intraoperative imaging. I would ensure there's a sandbag on the ipsilateral buttock. We'd have a tourniquet on and only apply if we need it, and we'll prep and drape the patient. Then you go on to what you're going to do in the operation. So in the first instance, I'm going to incision over the fracture side along the posterolateral aspect of the fibula. Then we're going to expose the fracture site with a self-retainer. So once you go in, you're in the fracture site, you're going to prepare it by removing all the fracture hematoma and soft tissue that's between the fragments, the proximal and distal fragments. You reduce it with the crocodile clamp or point reduction forceps. You get your intraoperative image, make sure you've restored your length, your rotation, and you're happy that it's in a good position. And then you put a lag screw and a neutralization plate. Now, I've put in between brackets fibular because, at least from my experience now, we're using it more and more in fibular plate in real life, but you can still say neutralization plate in the exam. I don't think you'd be penalized for that. So lag screw basics, you want to drill perpendicular to the fracture site. You want to over drill and you want to over drill the neocortex and under drill the far cortex so you can get adequate purchase. You measure, tap, countersink, and then you insert your lag screw. Then you say, I'm going to put a third tubular plate with 3 screws proximal and 3 screws distal. Cortical screws proximally, cancellous screws distally. The reason is you have more cortical bone in the diaphysis and therefore better purchase, whereas in the metaphysis and epiphysis is more cancellous bone, so use cancellous screws. You then say, I'll turn my attention to the medial malleolus. You do a medial or anteromedial incision. You prepare the fracture site pretty much the same way. Either pointed forceps or you can use a K-wire. You drill or use a K-wire for anterior and posterior screws because you're going to need two. And you're going to use two partially threaded 4 mm screws, cancellous, they're at least 4 cm in length with a washer. Then you do your assessment with the hook or stress test, insert a screw or tight rope if unstable. And then closure, you make sure you get your final images, you close the wound, you put a slab, you make sure patient's safely transferred off the table, you write your up note, and you sign out. Again, I know practically this sounds like a lot to do, but the more and more you discuss this with a colleague and you guys bounce it off each other, you can do this in about 2.5 minutes tops. For an X fix, same thing, ensure a team brief was performed prior to sending patient, marked and consented, blah, blah, blah. So position, I want to make sure there's supine, a radiolucent table, sandbag, tourniquet, use it if I need to, prep and drape. So the things we need to talk about with tibial pins and calcaneal pins is just, I think knowing them is good. So the Shan's pins are the ones we use for tibia, and it's the denim pins we use for calcaneus. So you say using intraoperative imaging, I want to mark out the fracture site. I need my pins at least 3 cm proximal to fracture site. You mark the tibial crest and you go medial to the anterior tibial crest. So if I show you a picture, so that's going to be anterior tibial crest. So essentially what we're saying is you go down with your skin stab incision, blunt dissection down to bone, get your drill. What I do is I feel the crest and then I start migrating medially and then you fire it that way. What you want to do is you drill your first cortex, but you do not plunge into the second cortex because there's badness in the posterior aspect. You don't want to cause neurovascular damage. And then you put the pins in with the T handles, so you have more control rather than putting it on what's it called, on power. Confirm the position on II, both AP and lateral, and then you can go on to do your calcaneal pin. So essentially, you mark it out. It's 2 cm distal to the medial malleolus, 2 cm anterior to the posterior border of calcaneus. And essentially, you want to go medial to lateral. Reason you want to do this is you have more control of knowing where your pin is entering, because obviously behind the medial mal, we have all our neurovascular bundle. If you're firing from lateral to medial, you don't really know where you might come out. You might come out posteriorly, and you're in big trouble. If further dorsiflexion needed, so you've done your calcaneal pin, you've put your 2 tibial pins, it's still not in the best dorsiflexion, then you can put a first metatarsal pin. I think it's worth just mentioning that, again, depending on time. But the most important things, I think, is the tibia and the calcaneus. So the best placement is a triangle delta formation, as I've shown here. You check your reduction on AP, you apply your traction, you put your connectors, take final images. Where the pin sites are, you make sure you put gauze and you cover them correctly. And then you would state that you would plan definitive fixation with the span scan plan management option, really. And that's it from me. I hope I didn't overrun.
No, well done, Chad. That's very good and very thorough. Perfect. Good. So we just in a rush because of the time. So Adham will be going through the spine station. Yeah, thank you so much. If you just send me the slides on the WhatsApp, so I'll keep it in the group just to stay there rather than the chat, which will disappear.
Okay.
Good. Thank you so much. Go ahead, Adham. Up to you. So Adham is a post-CCT spine fellow in Newcastle. is one of the best candidates ever. So I think, yeah, you will have a very good one. So Adham, please.
Can you hear me now?
Yeah, we do.
Yeah, thank you very much for the introduction. My name is Adam Musa. I'm a senior spinal fellow in Great North Children's Hospital. And I understand this presentation is for the SHO's level CT2 registrar who maybe have started 1 year or 2 years. Some others who have very extensive experience in orthopedics, but they're still very keen on getting into the training. So it's important to titrate your level of answers in your ST3 clinical station and even prioritization station to the level of ST3. You don't want to appear as overqualified or subspecialized in spine or any other specialty in orthopedics. So if you know more, try to keep it to the basics, to the safety area. Always seek help of your senior colleagues, etc. So this station or this presentation is tailored to everybody to be at the same level at the point of the interview. So learning objectives, understand how spine appears in ST3 interviews, recognize the high yield spine topics, learn how to structure your answers safely. Spine station in the ST3 is the safety question. So if it comes to assess how safe you are, rather than much knowledge, really. They're not expecting you to know any surgical intervention for spines or anything like that. It's mainly a safety question. They want to know that you can communicate, that you can escalate appropriately time-wise. And practice one mock station question. Where the spine appears, it appears predominantly in the clinical station. One of the two questions that comes, so it will be 5 minutes scenario that you will need to go through. It can come in the prioritization station as well. If it comes as in one of the cases is conda equina, so obviously you have to prioritize this overnight. You don't need to wait until the daytime to proceed for decompression surgery. Communication, I don't think there is any communication station at the moment. Assess safe core orthopedics, that's what I'm talking about. Assess your safety, and big deal of the ST3 success is how safe registrar you are. Examiner expectations. So they expect from you to answer structured wise, to have systemic process of thoughts, and taking history, examination, investigations, what's your differential diagnosis, what your line of thoughts, all these kind of things. They're assessing for this, and they're assessing your safety. That's the main thing. And appropriate escalation. Some of you will be already spinal fellows or registrars somewhere overseas or in the country, and they're very keen of starting training from the start. Do not talk as a spinal fellow. That may fail you the station, even if you talk better than the examiner in front of you, who maybe not, or 100% is not, most of the time is not a spinal surgeon. So you may know more than them, but do not show this or overdo it. High yield topics, anatomy, very common questions and it's becoming to me more and more common in the ST3 interview than in the past. 10 years ago, there was no questions about anatomy. Now it's becoming to be at least half of the first question and second question will be circulating about anatomy. So you need to know your anatomy very well in all orthopedics and neurology for spines if it comes. You need to know what's the difference between radiculopathy and myelopathy. Coda equina is a must. Spinal trauma, yeah, it can come as well. Imaging choices to be able to appropriately select your next imaging. Applied spine anatomy, that's what we talked about, to know about your dermatomes, what dermatomes apply the upper limb, what dermatomes apply the lower limb, know them by heart. You do not need to appear as rolling your eyes up in the ceiling trying to remember what C5 supplies. These things has to come straight away. Once you asked what supplies the badge area here, or the lateral forearm, medial forearm, middle finger, thumb, all these kind of things, you have to know them. Spinal cord blood supply as well, it can come. We ran out of time a little bit. I wanted to spend some more time to give you knowledge from the station as well, but you can always study that at home. I'm here today just to open your eyes on what topics can come in the spines and how the examiners are thinking to give you answers, to give you marks during the station, rather than try to feed you knowledge. But yeah, you can find these: spinal cord blood supply, anterior spinal artery, which if it got affected by injury, it can cause anterior cord syndrome, posterior spinal arteries, the artery of Adamkiewicz, or greater anterior medullary artery here, the segmental arteries that comes along from the aorta to the spinal cord. These are important to know. Upper and lower motor neuron lesions, you also expected at the level of ST3, because you're gonna cover nights which covers spines in some areas, and some of you will start as spinal registrar. So there is no way that you start a spinal rotation without knowing these basics, the difference between upper and motor lower. It may not come it may be not that common in the ST3 questions, but it's extremely important for your knowledge to be at the level of ST3. So you expected to know the difference between upper motor neural lesion, hyperreflexia, the absence of the tune in the lower motor, and the lead kind of bending hypertonia in those with upper motor neural lesion. Sticking something. Yeah. Asia score, that's the communication sheet. If you mention that in your spinal cord event, any event in the ST3 scenarios, including the coda equina, because coda equina is essentially type of injury to the coda equina. Yes, it's not the spinal cord, but we still, for coda equina patients, we still refer them after surgery to the spinal cord injury units. So we deal with coda equina as a spinal cord injury. The Asia score is well known internationally for documentation or the way of communication of patients' deterioration or improvement of their neurological symptoms. And as you can see, it's extremely important to know how you examine your myotomes. So the C5, elbow flexor, C6 is wrist extensor, C7 is elbow extension or wrist extension. Elbow extension. C8 is the grasp or the power of hand. T1 is fingers abduction, and the same for the lower limbs. You need to go through this. You make a kind of mnemonic in your head, or way like I used to do, like this is kind of a dance or something, anything that will stick to your mind, because it's really difficult in the pressure and the stress of the interview to remember these things clearly if you don't have it in by heart in your memory, essentially, and practice them a lot to talk about them verbally. Common presentation or cases that comes in the ST3, I always say exam. Deal with the ST3 interview as an exam. You have to impress those people. Those are the examiners who have your kind of career in their hands. You need to impress them by your professionalism, by your communication, by your nice smile in your face, how lovely friend, or not friend, I mean a colleague to work with them, and that they need to trust you for them if they are over the weekend, they want to stay at home and you're gonna be safe in the hospital. So the cases that comes is mechanical back pain, sciatica, spinal stenosis, not as common, cervical myelopathy, semi-elective or more of urgency, and coda equina is emergency case. So again, you need to know what is elective in the spines, what is emergency in the spines, and what is in between, like tumors, for example. You've got 2 weeks to deal with them. Unless there is spinal cord compression, again, you need to deal with it as coda equina. Red flags. Red flags, you must not miss that in the exam, and it can come in the prioritization station. They will in the middle of the scenario saying the patient presented with bilateral leg sciatica and saddle anesthesia. Otherwise, whatever, feel all right, or they try to reassure you in the scenario just to kind of not put the red flag as sandwich between other reassuring signs. So you say, oh, that's fine, I will do it tomorrow, or like later on, or can be cancelled. And that will be a killer question. It's like a trap question. So you need to be very alert to any red flags when it comes. Saddle anesthesia, bowel or bladder weakness, incontinence, essentially, which we call double incontinence, progressive weakness of legs or arms, night pain, weight loss, fever for infection, etc. Imaging, what to choose. If it's fracture and trauma scenario, X-ray is a baseline. Even if you are like tertiary center, you have CT trauma to start with. Even if you do trauma, CT trauma, sometimes we need X-rays along with the trauma because it shows the alignments and it shows other things. So know your basics: X-ray, CT scan, MRI scan, which will show you the soft tissue. Management of any acute spine. If it's trauma, you're talking about immobilization, full neurological examination. You have to do that. You have to document it. You have to communicate it appropriately, as we mentioned. If it's trauma, spinal cord injury, then through Asia chart or communication by documentation and escalation to your seniors. Urgent MRI scan overnight, refer to different hospital if you don't have 24/7 MRI scan accessibility. So transfer to the spinal unit closer to your DGH. Early senior and spinal inputs. If it's elective scenario, then you know that conservative first, as the NHS will always try painkillers, physiotherapy, injections, etc. and that, but I don't think it will come as an elective event for you in the ST3. Principles for spinal trauma: you need to assume it's unstable. I appreciate how it's difficult to assess for fractures in the spine X-rays, especially at your stage of their career. So always deal with anything, just say, I am concerned about this. And it's fine to be concerned, and then it ends up with something that is not a problem, than being reassured and then you end up with a disaster. Always think about the triple immobilization if cervical, And remember, your ATLS is A, B, C, D, E. The A includes not just airway, remember cervical spine. Extremely important to mention that. CT trauma protocol for everybody. There is both guidelines, as Jade was talking just before me, both guidelines for spine. There are about 4 or 5 for spine in general, talking about cervical spine clearance, spinal cord injuries, spinal fractures, different ones. You need to download them from the website, the British Orthopedics Association, and know them by heart. MDT decision making, always mention MDT is like a buzzword. You will get a mark for just saying MDT approach. Complications, neurological injury, infection, dural tear, persistence pain. These are complications for surgical intervention in general that you can send the patient for, but I doubt you will reach that area in the 5 minutes scenario. So, mark scoring. Back to the meat. What you're gonna get marks for is this order. History taken, you're not missing red flags or important specific questions. So remember, you've got only 5 minutes. Probably only 3 minutes out of these 5 will be pure time for you. You don't want to waste your time, taking history, where do you live? You need to ask 3 or 4 questions that is straight to the point. Have you got any urinary or bowel incontinence? Have you got full control of your bladder? Do you feel the water coming out while you urinating? Do you feel you have full bladder or not? How urgently, how frequently the time, when was the first time you had the incontinence event? Why? Because if it's for more than 48 hours, the prognosis is very poor, even with surgical intervention after that, according to the literature. So 4 or 5 questions straight to the point. There is no time to fuff around and ask random questions, general ones that covers everything. This is not gonna work. You're just wasting your time and you're not sorting the marks out. Examination. If you know your age score, you will know what you're examining. So you will say, I will examine this by doing this and that. I will ask the patient to kick out against my leg, etc. Your differentials before investigations, differential. You say, well, I'm very concerned here about coda equina, but remember, coda equina, it's not just caused by disc bulge, it can be caused by infection. So coda equina is a compression syndrome, is a compression of the coda equina nerve roots that are coming out from the end of the spinal cord. So the compression can happen by anything, trauma, infection, tumors, anything. So you need to know what is causing this. Is it a herniated disc, which is most commonly, or infection, epidural abscess, or tumor? So you say, I'm concerned here about coda equina because there are red flags. And the reason of this, it could be this or this and that. That's your differentials. Investigations, you have to say, again, straight to the point. I know that MRI scan is the golden standard investigation, but I would have to do bloods to rule out infection, including multiple myeloma screen, including this, bladder scan, all these kind of things. Again, to show them the line of thoughts that come into your head, and then management plan. You can't reach the management without starting saying escalation to my seniors. This is a safety thing. You're not in the hospital to manage people by yourself. You've got seniors. You have to involve them timely. And safety netting, which, when you discharge patient, if you discharge patient that you don't think they currently have coda equina, so there is no emergency, but they have massive disc in the MRI, you have to tell them, if you got the red flags, please come back straight to A&E. Right, who's ready to take this 5 minutes coming? We've got 10 minutes left in our session. who's
Thanks.
ready.
Yeah, thanks, Mr. Musa. So that's very nice presentation. Can I add a few things, please? Because I've just done the exam very recently, a few years ago. So when you're in the interview,
Well, Ahmed, can I ask you to do that after I leave because I have to leave in 10 minutes.
yeah, okay, yeah,
So
that's fine.
I'll finish the mock question and then I will leave you for your talk after that because I literally have to leave in 10 minutes. So
Yeah, that's fine. No problem.
all right.
Yeah, sure.
Right. Who's happy to take this case?
I'm happy to do.
Excellent. Right. Let me put a timer. Guys, I can't stress enough on the importance of practicing with time. Because we can talk about Coda Equina for next 2 hours, but the trick is to how you talk about it in 5 minutes with examiner interrupting you. So that's another skill that you need to train your brain and your mind about it. And the other thing is 30 minutes of ongoing questioning and talking. So again, you need to train your mind how to keep working for 30 minutes without exhaustion. So probably practice more than 2 hours. So you've got the stamina to keep going without losing your concentration. So back to you. What's your name? Sorry, my friend.
Muhammad.
Muhammad. Right. You've got 5 minutes starting from now. We have 55 years old gentleman who presented with severe back pain, bilateral leg weakness, and urinary retention. What do you think is going on with this gentleman?
So the 55-year-old patient with almost 3 or 2 red flags for Coda Equina, and it can be also a cardiac compression on a higher level. So I will start assessing this patient, taking the history, starting most specific.
What questions you will ask about in the history?
First of all, I need to ask about any history of trauma, any history of malignancy, because it can be metastatic or traumatic event. Also, I will screen this patient for any signs of infection, asking if he have any constitutional symptoms. We'll ask also about his symptoms, when did it start, and if there any history of similar episodes in the past, which may indicate a chronic issue which has been aggravated. We'll start asking a more specific question about his urinary symptoms, if he can feel it or if he can't, and I will start doing neurological assessment. I will mainly examine, I do a preanal examination to check the sensations around the back passage, and also do a full neurological assessment of the lower limb. Make sure that I am doing sensor assessment, motor assessment, and they will also check for the reflexes. I will complete my examination doing an upper limb assessment to exclude any higher up compression. We'll complete that doing an X-ray, bloods, and doing bedside tests, including urine.
How do you document your examination findings?
I will use an issue chart to document the neurological assessment and complete all the things I mentioned is a finding of the X-rays and the rest of the examination in the patient's notes, and to make sure it is accessible if I'm handing over this patient or transferring him.
Say you are in a DGH hospital and it's now about 12 o'clock. So you've got only 8 hours left before the daytime starts MRI scan. Would you keep the patient and keep an eye on them for observation until the morning, or what are you going to do?
Most of the time is depending on the accessibility of the.
You don't have MRI scan overnight.
So what we do in our daily practice, we try to refer this patient to a hospital where there is an MRI scan can be done. Usually we transfer it to a major trauma center or a unit which do spine or have accessibility to the MRI scan. As a management of the Coda Equina as an orthopedic emergency based on the literature, if there's a confirmed Coda Equina, surgery should be done within 24 hours for those patients in retention and within 48 hours for the patient in incontinence.
Okay, anything else you want to do for this patient?
So I will keep the patient ill by mouse and prepare him for surgical emergency surgery. I will do his bloods and explain to him the current situations. We'll transfer him to get an MRI scan and be ready for the surgery.
Do you want to tell anybody about this patient?
This patient should be discussed with my consultant for sure initially, and to be handed over properly to the spine surgeon in the receiving hospital, just to highlight up him if he need to go to theater overnight.
Excellent. What operation would you offer this patient?
So, Coda equina is usually treated by a spinal decompression based on the finding of the MRI scan. If it is a bony element, if it is an instability element, if it is a disc element, we'll decide
What
later
are
on.
the causes of Coda equina?
So, cause of Coda equina can be as I just mentioned, traumatic, can be disc element, instability, and can be malignancy, and it can be also infection.
Excellent. Okay. Right. So you've done the procedure and the patient post-operatively still having a problem. What are you gonna do? Still having the same symptoms. He hasn't improved when you examine him post-operatively. Tell me in 2 minutes, in 2 steps, what you are going to do as a registrar.
First of all, I should reassess this patient again, checking his history, checking his operation notes if there are any intraoperative complications. If I can't find the problem through the patient assessment, I will discuss with my consultant what is going on, and I can start trying to find any other cause.
Would you re-MRI him again?
We re-MRI actually after the.
What you thinking of?
Why thinking of initially can be a post-operative hematoma compressing the
Excellent. That's it. Thank you. I give you extra 10 seconds just to say that. Well done, Ahmed, you said? Muhammad, sorry. Well done, Muhammad. The only thing I would say, I had to prompt you 3 times to say, or 2 times, sorry. You said it in the third time without prompting, to contact your seniors as early as possible. So once after the examination, once it comes, it's like compartment syndrome. These emergencies in orthopedics is only 2 things: compartment syndrome and coda equina. These 2 events, once clinically concerned, you escalate it. You say, I know I will need to arrange MRI scan or transfer the patient, but I will also escalate that to my senior colleague consultant on call, because I understand this is emergency in orthopedics and we need to intervene sooner rather than later. Obviously, if you are in a tertiary center, you really need to open theaters overnight. You don't need to wait.
Yeah, and the other thing you might need to mention the Grift pathway as well for the coda equina. So you'd say, I would assess this patient based on the Grift pathway. When did the symptoms start? Is it less than 14 days or more? And based on this, we need to get MRI scan within 4 hours from the request.
There are guidelines that I'm sure my colleague Ahmed Mustafa will explain things and give you the links for them and share them with you. Right. So the model answer, exactly as you said, the onset and the progression, the red flags, blood and bowel function, past cancer or trauma event or infection, full lower limb neurology examination, perianal sensation, anal tune. If you will do it. They may put like obstacles such as a patient refuse. You will say, okay, if patient refuse, I'll explain them the consequences of this problem, because clinically you cannot assess without documenting this in the notes, and it's extremely important for the prognosis of the patient and medical legal wise to assess this before any further intervention. Document findings clearly. I prompted you for this point as well. And now remember, the 3 points I prompted you in is the documentation of your clinical examination, timely. You finish the examination, you go out, document straight away. Emergency MRI scan, as you said, bloods to rule out infection, multiple myeloma, tumor screen, etc. Avoid any delay. You say that. You don't assume that they will understand that you are in a hurry. No, you say, I will avoid any delay in my management because this is emergency in orthopedics. And Nick Fash, sorry, I didn't say Nick Fash, because Nick Fash now in our tertiary center, it's more of like plastics thing, but also sometimes the referrer comes to you, you deal with it because it's emergency, and then you involve plastics sooner rather than later. Don't say like, oh, this referral goes to plastics. As a doctor, you have to start the process of emergency call and then call plastics to be involved. This is the MRI scan, how it looks for Coda equina. It can look like this, as bad as this massive disc stopping any CSF or nerve root visualization. Coda equina syndrome, urgent spinal referral, emergency decompression, as you said, if confirmed. Safety netting, documentation, clear documentation, escalation to consultant, time critical nature noted, examiner tips. Again, early recognition, you will take mark for this. Use of MRI, you take mark for this. Escalation and urgency, structured approach. Why do we lose marks in this station? Because you missed a red flag, you delayed the imaging, you keep talking about other things, and overcomplicated plans, or talking or acting beyond the ST3 level. If you talk like a spinal fellow or post exams, that's not in your side, it's actually against you. Take home messages, spine questions are common, it can come. Safety, safety, safety. That's why this question is there, is to assess your safety, not much about your knowledge. Structure answers and escalate early if you can. Practice, practice, practice verbal answers, use frameworks, always stay calm and systematic. So don't appear as adrenaline, and stay calm. You know, your facial expressions, your body language, stay calm, but your actions and the words you're saying will explain the emergency rather than being, you know, anxious. And you know, it happens to me personally because sometimes it's out of control, but try to stay calm and having a very calming body language. And as I mentioned before, act as a registrar. Just feel it. You already a registrar and you just want to prove that you're safe. That's all. I will leave you now to my friend Ahmed Mustafa to carry on with the extra stuff and the higher level of knowledge. As you can go all the way up to the FRCS level, we all are post exams and we have a lot of knowledge, but I don't think you really need to worry much about how much knowledge you have. You only want to prove you are safe, you know what you're talking about, you know your guidelines. If you just say greft, for example, as Ahmed said, or you know, quote something from both guidelines, that's it. Full mark, no question. All right, I have to leave you now to Ahmed, as I really have to go.
Yeah, exactly. This is all what I wanted to add, actually, Dr. Musa. There was nothing much. Your presentation was really thorough and informative. So just make sure that you code the NICE guidelines, both guidelines, and the GREFT pathway. But the answer that Mohammed has said, it looks really ideal to me and looks really good.
Yeah, well done, Mohammed. You did extremely well.
Exactly. Yeah.
Right. I'll leave you now with Ahmed for any questions or anything. All the best with you. And Mr. Hashim, we're very happy to give you another session closer to your interview if you want, and I'll leave that to him to sort out. And I wish you all the best.
Thanks, Adham. Thanks for your time. And yeah, it's a weekend. So yeah, good luck with what you're going for. Thank you so much. So yeah, Ahmed, if you take over because we have to break, so we have 5 minutes.
Yeah, exactly. So yeah, I don't think there was much for me to add. So the only thing that I want to add that in the SC3 interview, the main questions that I hear that they have been asked in the exam was the Coda equina scenario and the scenario of trauma, of spinal trauma. And if they ask you a scenario like this, they're not expecting you to get into too much details in terms of like the approach or will you do discectomy, or we do laminectomy, or we do like full decompression of both? So these are not the things that you are asking about. So you want to make sure that you are safe. You ask targeted question in the history, and when you say I will examine the patient, you will just go quickly through the examination. You don't need to get into too much details. I will assess the sensory of like C4 and 5 and L1 and 2 and things like this. So you want to make sure that you say I will get the growth pathway, ask for the red flags of Coda equina. Are they less than 2 weeks? And I will document everything, get bladder scan and so on, and then move to the management, make sure that the patient is starved. I will send up to the bloods group and save. I will escalate to my consultant. If we are in a DGH where we don't have out of hours MRI, we don't have spinal surgeons on call around, then I will refer this to our regional spinal unit. After making sure that I have documented everything, I've sent the formal referral with all the details, and then we'll take it from there. And the other scenario for the spinal trauma, make sure that you always mention the BOS guidelines for imaging of the spine. Make sure that you discuss with your consultant, mention the ATLS precautions, and remember before the A is always C, spine protection. This was just for the 10th edition. I think this might change in the 11th to be stop bleeding. But again, the C is critical to be protected. That's it from my side.
Perfect.
All right.
So good, guys. So next will be a break for 23 minutes. We'll be back on 1:30 for the mock. Mock, guys, is there is no pressure. The point is we need you all to be on board with what's going on. So just try to familiarize yourself with these breakout rooms. So they will be in couples. So one and 2, 3 and 4, 5 and 6. So basically, it will be 2 cycles. Every cycle will be a 40 minutes and 5 minutes in between. So every 4 candidates will have 4 scenarios from the faculty in the room. So they will run through 8 minutes of practice for every scenario and 2 minutes for feedback. Then at 40 minutes, in the candidates in room 1 will go to room 2. The candidates in room 2 will go to room 1, and same for the 3 and 4, same for 5 and 6. So just familiarize yourself. Breakout rooms will be ready once you're back from lunch break, and then you will be assigned to every room to start with. Then once your time is done, faculty will control the time in the breakout room. And then once the time is done, you know that you need to move from 1 to 2, from 2 to 1, from 3 to 4, 4 to 3, 5 to 6, 6 to 5. Then we'll go for another 40 minutes cycle of practice. Again, 4 scenarios for every candidate, and 8 minutes practice, 2 minutes feedback. And hopefully this will be of use for you. At the end of the day, we'll do a debrief. So just to put some minimal feedback, 6, 8 questions, just to say, what did you find well, good, what did you find not good, or you feel that it could be better. And yeah, the formal feedback will be at the end of the course because that's needed for the CPD certificate. Guys, again, I have to emphasize that it's 80% attendance for the course is essential for the CPD certificates. 79% we will not be able to issue the certificate with the rules of the Royal College. So you need to be there for 80% of the course and to fill the final feedback. Good. I'll leave you now to the lunch and prayers. So we'll be back at 1:30 sharp, and breakout rooms will be ready at that time.